Hey guys, welcome to another episode of the Fix Yo Shit Show. I'm really excited. A very special guest. His name's Dr. Jared Ament.
Happy to be here.
And he is a board certified neurologist.
Neurosurgeon.
Neurosurgeon. Neurologist versus neurosurgeon.
Yeah. Different.
How?
Different tracks. Completely.
Completely different tracks.
Different residency, different specialty.
Okay.
One is very much medical. One is more surgical, obviously. One looks at things like movement disorders, dementia, neurologic diseases, and other looks at kind of mechanical, biomechanical processes, tumors, things like that.
Interesting. Okay.
Yeah.
I actually didn't know that, actually. I kind of thought they were kind of one and the same. It's just maybe a different residency at the end.
Different residency completely.
Okay, got it. Because you went to school obviously got your bachelor, then you got your medical MD, DO? MD. And then after that, that was a residency to become a neurosurgeon.
Correct.
Okay, got it. And that was fellowship trained neurosurgeon. Is everyone fellowship trained? What exactly does that mean?
It just means you did extra training to focus on certain subspecialization.
Okay, got
areas.
it.
Yeah.
And what was that track specifically?
I was specifically looking at spine and biomechanics of the spine and how to do.
Oh.
With the particular people that I worked with, it was very much focused on motion preservation.
Wow. So motion preservation, I mean, I'm assuming it's a small subset.
It is a small subset. It's growing, thankfully, but the fusion mentality, which I argue is quite antiquated, 30, 40 years.
I would say it's like some Ace Hardware stuff. I mean, this is like prehistoric looking.
To me too, but it's still the standard of care.
Right.
And so it is, I mean, every year there's like an arthroplasty meeting that 30 of us, on average, attend from all over the world. And it's a very core, closely knit group. And we're trying to advocate. We're trying to collect data together so we can, let the data speak for itself and not just not us shouting from the towers, screaming at insurance companies, but really trying to advocate for our patients and the technology that wasn't always great, but is getting better and better and better. We want the results to speak for itself, and we want people to stop getting unnecessary fusions. Okay.
And so that was like motion preservation surgery, and that's one of your partner in that clinic, right? The motion, what is the name of that?
The Center for Motion Restoration.
Center for Motion Restoration. Guys, that's up in Beverly Hills.
Westwood is that center.
Yep.
We have an office in Santa Monica. We have an office in the Valley.
Okay. And you're also at the Cedars-Sinai Hospital. I said it right.
You did. Cedars, that is in Beverly Hills. So I have privileges at Cedars-Sinai where we do kind of our bigger, more complex, longer cases and a lot of our brain cases because I still do brain surgery.
What do you do with the brain? Like what kind of procedure? What are the common procedures?
Yeah, for me at this stage of my career and my focus, the most common is going to be brain tumors. And I do a lot of facial pain syndromes, trigeminal neuralgia.
Oh, okay.
Yeah. So I do a lot of international volunteer work. And every year I go to Bolivia. And this last trip to Bolivia, philanthropic work through an NGO, was all trigeminal neuralgia facial pain, where we make a small hole in the back of the head and are trying to separate pulsating arteries from nerves that causes severe intractable pain. I mean, so much so that if you look back at historical records, there are patients who reported, suicide and multiple tooth extractions by dentists because of how bad and intense that facial pain was.
So this facial pain you're saying that the artery pulsating is in too close a proximity to the trigeminal nerve?
Correct.
And it's just every time it pulses it can hit that nerve.
Yeah. And I mean, there is good data to suggest that this is one of the most debilitating conditions and pain syndromes that anyone can experience.
Wow.
Yeah.
Okay, and then we
try medical management.
Yep.
And if that fails, there's a really beautiful, eloquent, minimally invasive, in quotes, because brain surgery is questionably minimally invasive.
Yeah, right.
But I mean, the hole that we make in the skull is about the size of an American quarter.
It's a big size hole, though.
Yeah, I've taken off the entire skull.
Okay, got it. Compared to
that. So I mean, comparatively, a quarter size hole under the microscope with little nerves and arteries, it's pretty minimally invasive, and we can get patients home after a day or two in hospital if it's successful.
So you reroute them ultimately?
So we create a separation.
Put it in like what do they call the brain? The fissures. You just like put it inside of a fissure.
Yeah, we separate the we actually don't go anywhere near the brain, which is kind of nice. We are in fissures, arachnoid spaces. We don't actually go into the brain itself, which sometimes you have to do for tumors.
I see.
And we're kind of working through natural corridors. And then we actually create a little Teflon patty that creates scarring to separate. We put a patty that's sterile, and we put it and separate the artery from the nerve, and it scars in place. And the success rate for patients who are well screened with typical, because of course atypical, but with typical pain, it was like an 80 to 90% success rate.
Huh. Wow.
Yeah.
Yeah, that is not an area where I have really any understanding of that. So
no,
it's
probably
so
nothing, and not related to anything we're talking about today, but it is certainly, pain is a fascinating thing. And this is one of those conditions that really is so disabling that there's medical legal literature that will state that if a patient has typical findings with a diagnosis, you don't even need imaging, and it's kind of the antithesis of spine world that we're talking about. You don't even need imaging to corroborate the finding. It warrants surgical intervention if it fails medical therapy, because the risk of opiate abuse, suicide is so high in this condition.
I see. It's considered like an emergency.
Yeah, it's a really sad condition for people who are not getting treated appropriately.
You know, I got introduced, this was 15 years ago, there's a school called Prague School of Rehabilitation. It's in Prague, Czech, and it was founded by like some old school PTs. It's still around today. And I saw there's something called DNS, dynamic neurostabilization. And I saw this with my own eyes. I'll never forget. Someone had complete Bell's palsy.
Yeah.
Okay. And I'm not sure I can't accurately go over describe the mechanism, but they take people back to old kids to like cross crawl patterns and different eye movements.
Mm-hmm.
And they'll take them. I saw this guy go from droop to a normal face in 20 minutes. I go, unbelievable. So that's,
wow.
You may have heard of the Carrick Institute.
Yeah.
So it's definitely in similar premise as Carrick Institute.
Okay.
But the Prague School of Rehabilitation founded a phrase that stuck with me, and it was called joint centration. And joint centration is the optimal position of a joint. It is both a static and a dynamic position where there's maximal surface contact, 360-degree pressure distribution, which equals a 360-degree muscle balance. And so joint centration is ultimately what I built my entire methodology off of, is centrating a joint. That a centrated joint wears appropriately. Like,
this is why we're talking.
This is
why I enjoyed our initial conversation, because the concept of joint wear and tear in the setting of pathology or lack of symmetrical distribution,
right,
is what you're saying. I mean, this is what we're trying to create or fix or rectify in a pathological joint in the spine with motion preservation, which we often can't do, or we have limitations.
And this is why, I mean, I'm so excited to have you, is because you are one of from what I see, the few that care. Even the word motion preservation from a surgeon is
heresy.
It's usually about restricting movement physically and surgically.
And you know this as well as I do, the reasoning for that has always, and this is again 4 and 5 decades of reasoning, which needs to be updated, right? The reasoning has been that when you have pain from a failing joint or a failing part of the body, people attribute that pain to malalignment or incorrect motion. So if you're having incorrect motion or irritable motion, stop the motion, stop the pain.
Right. The old way. Stop doing it.
Sure.
Right. And you can probably agree that, let's just say, for example, let's just say we're on joints. So let's just talk about like an L5 facet joint.
Sure.
It's that stop the movement. Well, and I'm sure you see in there that it would, maybe by the time you would even operate, that whole facet is osteophized.
Sure. Or destroyed. We'll see, like we talked about, tops and all this stuff, or we'll probably get into it, but when it needs that level of surgery, it's a destroyed joint.
Yeah. But that joint pressure distribution, the old model's like, the joint. I'm like, it started at a pinpoint portion of
absolutely.
That joint.
Yeah, absolutely.
And then eventually, it will obviously overtake.
Yeah.
Goes into the foramina,
causes
stenosis, etc. But those but I really want to get into you today, dive in with the specifics of pathomechanics, those pinpoint, like for example, the acetabulum, labral tear. When people go, I have hip arthritis. If you look statistically, starts with labral fraying, turns to labral tear, the bone starts to grow, cam pincer, osteoarthritis. But it is at nearly the exact same pinpoint spot where it starts on the anterior. It'll be on the medial anterior superior aspect of the joint. And that is the original collision point. And so instead of people going through to, oh, you have hip arthritis, I'm like, well, it's only on a certain point. And that gets me to the next point, which is rest. People are like, rest. I'm like, okay, but resting, if somebody has a facet joint issue, resting actually is putting more spinal flexion in. Not laying in a bed, putting more spinal flexion.
You want to offload the facet.
Offload the facet. No.
But this is, I mean, look, and so everyone knows who's watching, I'm getting no kickback from you, but I'm going to support you here a lot because I truly believe that people need you more than they need me. I really do. And that's not, I mean, again, there's no relationship here at all.
No.
Yet. Maybe we'll develop one. Yeah.
Maybe so.
But the point is that it really, I truly believe too many people are getting surgery. And too many people and if they're getting surgery, they're also getting the wrong surgery. And if people like you are able to help patients and identify that pinpoint episode, that moment in time where you have an ability to correct the problem so you don't come to me with a destroyed facet joint. We don't need to get to that point. You may inevitably, but if you can put it off 5 years, 10 years, and live a good, high quality, high functioning life, for me, it's not even just looking at the facet joint in isolation. It's about the global spine health, musculature health, core health. That's where you come in, and I think it's critical. Either before surgery, prevent a surgery, or after a surgery.
Right. But you have a master's in public health from Harvard, right? And so that's an interesting path to take first.
Okay.
Was this part of the plan?
Yeah. So I mentioned before about my Bolivia trip. So I was always from a very young age into international health, volunteering. I volunteered when I was even a teenager, not knowing anything about medicine, to like build paths and latrines and forests in the jungles of South America. So early on, I thought that the best way to help people was to go overseas. I've later learned that we have different but big problems domestically too. But and I still do both, and I always like to give back, and I bring residents with me, and it's a really important part of kind of my practice and my being. But the Masters of Public Health was designed to look at cost-effective analyses, cost utility, healthcare economics, and how to provide technology and better care to non-industrialized countries with less resources. And that was just part of the grand plan of trying to do better, what we do here and abroad.
I see. And so I saw I was reading some of your, because you've published about 12 or so different papers.
I think we're close to 40.
Oh, is it 40? Oh,
yeah. But that doesn't matter. But that probably 12 related to this topic.
Sure. And so the reason I brought up public health is because, and this is, and I want to share with you my side here too, from my experience with this thing, just so, and I think many of you know, is that I've been in healthcare since 2000. I started, right? Started in a chiropractic clinic working with rehab. I did like BOSU balls and things back in the day. Yeah. My wife's actually the CMO at BOSU right now. But, and then I went into chiropractic school, and the degree itself, I really wasn't connecting with it, honestly, this whole subluxation. By the way, I'm like ostracized from my profession.
I love it. That's why
I have a license still, but this whole thing about the adjustment being like this thing, I never really connected. So then I moved into functional movement, came out here to Cali. And then since then, working on having 50 new patients a month, working this, and then starting to get referral networks with different pain management groups, volunteering at the VA, having different orthopedic surgeons refer, different MDs, right? In this whole system, workers' comp, this. Yeah. And I left the system. I became so frustrated in 2017 just because I go, this system is not designed. The reason I ask about public health is because I go, this is my, maybe you call it a negative view or a darker view, is that this whole beast of medical, look, medical owns it. They have the power. They have MDs, DOs, surgeons underneath them. They even have PTs handcuffed to them still. It's this whole unit and we're in a capitalist society. It is a profit-driven model.
Very much so.
Yeah, look at hospitals. They're looking at 15% over year. Yeah. Surgeons, if you had every person help fix if you just guided them, let's just say I was right with you and I was working, you sent them to me, and let's just say amazingly, 80% of them I could help and they don't need it. You ultimately have $1 million in student loans you worked off, maybe more.
Sure.
from that.
Yeah.
And so the model is designed,
Yeah.
the more surgeries, the more money. The more chiropractic adjustments, the more money.
Yeah, I agree.
And the motivation and that's why we talk about this. I'm like, it sounds nice to talk about us together, but I'm like, what would even be the benefit other than from people who have not lost their morals to the morals of justifying surgery after surgery after surgery? Like, how would there even be room in such a system for me to even exist? I cost them money.
I'm not sure there's room for you in the system. That's we change the system.
Okay.
So I think I've always believed, do unto others as you want done to yourself.
Same, man.
And if you took away 80% of my volume, I still think that the 20% would grow because it would be the right 20%. The patient outcomes on that 20% would be even more, superior. And also, your model and what you're doing to me has a lot of utility in the post-operative recovery phase as well. It's not just preventative.
There is a lot of utility.
There's both. And so I've always believed that just do right to people. Business, things will come. There's plenty of people that you can't help. There's plenty of people even I can't help, right? So, I mean, knowing our limitations, I truly believe you just do right by people and it will all work out, And there are always other avenues. I'm still very engaged in research. So for me, it's not about operating on every patient. I always tell my patients, I don't want to be the hammer to your nail because it's just the impetus is too easy, right? That's the way the system is created. Like we talked about before we started this show, send for PT or pain management in 6 to 8 weeks. Oh, it didn't work. Okay, surgery.
Right.
It just doesn't make sense. We need, and this is why I'm excited about potentially working together on these things. We need better metrics. What does failing conservative therapy mean?
Right.
That's such a general BS, statement just to satisfy who? Insurance companies that are also for-profit entities?
To satisfy the doctor. Well, they tried everything, so I'll just do this.
There also is that. I mean, the inkling is try, failed. Okay, I'm now justified in my decision making.
Yes.
I think it's so much better to say, hey, this patient is failing because of these criteria, therefore maybe is a path to surgery or maybe is a path to some other method. We don't have that criteria. We don't actually know what does it mean to fail conservative therapy other than pain.
What is let's just say the general medical, we'll talk about. So what is the difference between a neurosurgeon and somebody who, a spine surgeon? Is there a different path for that? Or are they a neurosurgeon, but they just call themselves that for simplicity?
Yeah. So a spine surgeon, you can get to the area of spine surgery by two paths. So you can either be a neurosurgeon that specializes mostly in spine, or you can be an orthopedic surgeon that specializes in spine.
That seems like a more of a rare, right? Because most orthos tend to be extremity.
Most are hips, joints, shoulders.
I see.
But definitely you can do an extra fellowship, extra training. And I have plenty of very capable, excellent colleagues that go that route.
Okay. So let's just say, what is the criteria from the medical perspective? Just say your colleagues.
Sure.
On surgery. Because we have so many patients out there, so many people that go, I think I might need surgery or I might choose surgery.
Yeah.
And so what is the general criteria for surgery versus what is your criteria for surgery currently?
Well, I mean, in general, I would say that the easy answer to that question is, especially from a neurosurgeon's perspective, is neurologic loss of function, right? So if you have a trauma, your spine is severed, we need to put the spine back together. We try to get you into rehabilitation. If you have a sequestered disc that's crushing a nerve and you lose function in a leg or you lose control of your bowel and bladder, you become incontinent. Those are neurosurgical emergencies. Brain, obviously, brain bleeds, trauma, aneurysms, tumors. Those are not questions of, I want a surgery. Those are like, we have to do something to intervene to save your life or limb.
So we would call that a knee, because what people do is they go, I had to have it. I'm like, you had to have it or you chose to have it.
Yeah.
That's I have to have it.
That's I have to have it. And most of what we're going to talk about is I want.
What percentage of people, what percentage of surgeries, not just yours, do you think they chose to have it?
90%.
Wow. I've always said 90 to 95.
There you go. We didn't discuss that before.
Wow.
Yeah.
Yeah. Okay. Chose is 95.
And there's it's an interesting segue because the really bad stuff I was mentioning, that's not a choice, right? Those are disasters.
Right.
What's interesting about my space in particular is the surgeries are becoming so good, so successful, so minimally invasive, meaning done often as an outpatient. You go home a couple hours after surgery.
Your space is in motion
preservation.
Okay.
Yeah. So people go home a couple hours after surgery. When we can do things easier, safer, faster, better, it becomes a little bit boutique, right? And so there's the option to choose when people are, people are into biohacking today, and are really looking at getting a full body scan, being optimal health. A lot of professional athletes that you and I both work with, they are so in tune with their body. If their pinky toe is off, they can feel it when they're running.
Some of them.
I
think everyone has blind spots.
Everyone's blind spots. But I think that as people become more in tune with their body, or they're biased about what they're in tune with or not in tune with, they are opting for boutique solutions because surgery is becoming safer and better. Mm-hmm. So I think that's why I'm talking 90%, 95% is a choice, because there's a lot of people like, I twinge the wrong way and therefore I choose surgery because it's the fix. And this is what you and I have talked about, is that, it's not that easy. We talked about our mutual friend and patient, Natalie. Putting in a disc in her, in my opinion, was the absolute right thing to do. But we are extremely limited in our choices and options for someone who's so petite and so active.
Right.
And so it's a question we talked a lot about. If I put you back into alignment, you love using the words alignment. I think that's a great way to kind of talk about
simple.
It's simple and it makes sense and people get it. If we put you back into alignment, are you going to be better, or are you just kicking the can down the road for another problem? And so I think choice is a really interesting issue and problem and luxury of today's medicine.
Oh, a luxury. Right.
And I think a lot of people who would look at the biomechanics of what you do and get into a program that you're offering, maybe would think twice about that choice, which is why, again, I love the idea of collaborating, because we can do better by our patients.
Well, what we should get into that we're writing down is the common things that patients say.
Sure.
And common things that surgeons say.
Yeah.
And one of them you said was, we just teed up, is improving mechanical alignment. I look at this mechanics. I've been trying to master mechanics for 25 years now, right? And whenever surgeons, and the surgery goes 6 to 8 weeks of failed surgery to fix somebody's mechanics, this person, and everyone out there, I've broken the body down into about 5 misaligned patterns. And if we take all common injuries, but 90% can be rooted to one of these 5, maybe 5 of these 5. They can have 1 or they can have 5. Number 1, valgus knee collapse, ankle in, knee in, hip drops.
Mm-hmm.
Number 2, anterior tilt. So hyperextension in the back, then flexion in the back, which you might call kyphosis in the back.
Sure.
Uneven hips, uneven shoulders, might be labeled as scoliosis. Mm-hmm. Scapula winging, and pretty much anterior tilt of the scapula there. And then we have a forward head position.
I think you hit it.
And I hit it.
Yeah.
So those are, every one of those patterns, this person has developed maybe throughout their life. They may have missed a childhood. Like, we have a core phase when we're a kid. I think it's like age 4 to 8. That's the time that we're designed to be developing our core. And if we never do that, well, our core pulls us out of hyperextension. Mm-hmm. It's not just the abs. That person missed that development window.
Okay.
So they're going to be fighting with an anterior tilt position,
sure,
which leads into kyphosis of the upper back. The body has to compensate. Yep. And the reason I'm getting at all this is because it has to do with time frame. These patterns that people have, they've been carrying them with them 24/7. So this anterior, they're going to initiate their squat like that. They're going to walk like that. They're going to run like that. They're going to golf like that. They're going to have sex like that.
Yeah.
And these people are unable to, when you ask them to, they're unable to posterior tilt and flex the rib cage down.
Sure.
Because-
Decades of that. How do you expect it to correct?
How do you expect it to correct itself in 6 to 8 weeks?
Right.
And so these patterns, and if you could, share your experience, I don't know if you're looking for this. Let's just talk about anterior tilt. Okay,
Sure.
Anterior tilt. We're loading now the posterior aspect of our facet joints,
Mm-hmm.
right? And now we have excess of pressure on that posterior facet, or just call it the facet in general.
Sure.
Over the course of time, the body, Wolff's Law, body's going to put more bone in there.
That's correct.
An ugly bone too. For some reason, God didn't make it smooth.
That is very, very true. That is Wolff's Law. So everyone understands it has to do with loading, and that you require load for there to be bony growth and remodeling. And the fusion doctors rely on that because they're creating a internal brace to stabilize the spine, and then Wolff's Law, and they have bony remodeling, and they want the bone to do that. Without fusion, what you're talking about, this compensatory mechanism, absolutely, as you load more, you'll get quote unquote arthritic changes, right? And those arthritic changes are not uniform, unfortunately. I don't know why God did that, but
Well, in terms of uniformity, for example, if there's a left, let's say there's a left, let's just say it's more of a stenosis in L5.
Okay.
What mechanically you'll often see if you're looking is that person is going to have a hip higher on the left.
Sure.
So now that pressure distribution combined with extension.
Yeah, it's not symmetric. Sure.
And so now you have an L5.
Right.
And the reason I'm kind of guiding this narrative here is because these people need to know that getting themselves out of these patterns and retraining themselves, for them, it's going to be like learning an instrument or learning a new language.
Yeah.
6 to 8 weeks.
I wholeheartedly agree. I think what's unique about this discussion is I agree with you, but you also agree with me that at some point your goal to kind of retrain and correct the mechanics may not be safe, may be insufficient, and we have no choice.
It can hit a brick wall sometimes.
Certainly.
Sure.
And so the question is always going to be, and the question I've always had for you since the moment we met is when?
When. And so I would like to go over in a little bit about if we can create a simple functional screen.
Sure.
That
doesn't exist, by the way, unless you created it.
It does.
Okay.
It does exist. I don't know if anybody's linked the functional screen with pathologies.
Got it.
The way that I've been working on. And here's the cool thing now is there's actually like Keynote Tech, a company that's now getting digital. So you have a LiDAR camera and you can screen it and objectively measure it.
Yeah. I mean, and AI is going to also start.
Oh yeah.
Absolutely.
It's catching up real quick.
Mm-hmm.
But so the 6 to 8 week criteria of failed conservative care, it's like, who even knows what path they were on for that?
Yeah.
What do you think should be like maybe a more, because you're trying to help all surgeons, right? You're trying to be like, hey, if we all, because you're trying to do that now. You're in these arthroplasty seminars.
Yeah, I'm talking all over the world trying to get people doing the right thing. The idea is 6 to 8 weeks is, I don't know, it's bogus. It's also different depending on the payer, right? Depending on the insurance company, right? I don't know where the model came from in the surgeon community, but we basically rely on the insurance company to say, okay, they failed conservative therapy for 6 weeks, 8 weeks. Some are 3 months, some are 6 months. I think the timeframes are bogus. I don't think there should be a time frame. I think you're right. It should be a functional screen. And we have a baseline. We have a pathology, a pathophysiology, pathobiomechanics. And we give a certain amount of time based on the pathology, because I think it should be different depending on the pathology. And if there is no improvement, and that would have to be quantified, after a certain amount of time that we feel is appropriate, we have to figure that out as well. Then they may be a surgical candidate or an alternative therapy. I mean, we talk a lot about alignment. For me, when we talk about motion preservation versus fusion, it's much more similar to your space than not, because I'm talking about how do we put people back into alignment, but let their bodies also correct, right? I'm bringing up these models we brought it just to show people, but an artificial disc moves. If you're not thinking like you, and if we just put an artificial disc into someone randomly, there is a high probability of failure. And the high probability of failure comes from not thinking about the biomechanics, not thinking about the alignment. Because if you're malaligned, if you're naturally kyphotic, that disc is going to kyphose.
And the one above it's still going to do it.
And there's still the one above it and the one above it.
Below
And
it
the
and
one above it.
above it.
Absolutely. So the benefit of a fusion, F word, I hate it, but the benefit of a fusion is just a spacer. It's like a wedge, it's a shim. You can get at Home Depot. Joking, don't get it at Home Depot, but you know what I mean.
It looks like it.
It does.
If we were in a apocalypse, I can make this thing.
Absolutely. And you can sterilize it in your own machine. So the benefit of a fusion is I can correct your alignment permanently. I can absolutely put you into a perfect posture. But now I've done so artificially and your biomechanics aren't ready for it.
Well, you've actually put them in perfect posture at L5S1 if that's where it was.
Sure.
Which hopefully goes up. But
Yeah. Or you do. I mean, there are some people doing multi-level the whole thing, right? I mean, I've seen constructs. I don't do this anymore, but I've seen constructs from neck down. Perfect posture.
build it up.
But they can't move.
Can't move.
And so the question is perfect posture and alignment that's immobile truly the answer? Because you'll understand as well as me and a lot of our people who are going to watch this, without movement, there's going to be a whole cascade of other problems that happen, right?
A whole cascade. It reminds me of I forget the time frame on this, but they developed these seats for F-16s.
Okay.
And there was an ergonomic guy that came in there. And he built them all like he molded, he built them perfect for people. But they couldn't move in it.
They couldn't move in it.
They couldn't move in it.
And so if you have a hip problem or you have a knee problem, someone fusing your joint 40, 50 years ago, maybe, because it's the only option they had. Right? I've talked about this with Max and Natalie. Now you get a new hip, you get a new knee. The joints you're talking about loading and offloading and working biomechanics are designed to move. The disc is designed to move. So I don't believe that fusing everything together just so we get alignment is the right answer. But we both agree on alignment. So the question is, how do we work together to preserve motion if we're talking surgery? And we can talk about avoiding surgery, and I'm all for it. But if we are going to do surgery, how do we preserve motion and also maintain or correct alignment?
Okay, so I had a case today.
Yeah.
And I wanted to bring this up with you. I mentioned it before that I do with my members. I run a weekly Zoom.
Okay.
They show up. And she came on at the very end, and I had her, she said she has a sequestered disc, L4, L5, and she's getting a lot of like neuropathy down her leg,
Sure.
right? And I have her stand up, and she's in massive anterior tilt, and I have her squat halfway down, and she's still massive anterior tilt. And I go, this is unusual for a disc. Usually you're going to find disc, the curve is lost because they are flexing into the disc so much
Sure.
that it wears it out.
Yeah.
And so near the middle of it, she goes, oh, I want to let you know I had 20 years ago, I had a artificial disc replacement at L5S1. And she says about 4 years ago, she started, that's when she had an MRI, and it showed a sequestered disc or maybe it was like 2 years ago, L4, L5.
Level above. Okay.
So
Yep.
when I look at her movement, what happened mechanically is I asked her, I'm like, can you confirm that before there that your posture, that you were kyphotic and flexed? And she's like, I'm not sure. She wasn't sure. But now she's so anterior because she was propped up by a disc.
Mm-hmm.
But you have her do a squat.
Yeah.
She goes halfway down, folds into flexion.
Flexes. Absolutely.
She does a toe touch. It's not initiated by a hip hinge. It is a kyphotic flex. So now what's happened was that movement pattern that put her into surgery to begin with was artificially propped up on one level with the disc.
Right. Didn't correct her. Yeah. Didn't correct her.
And now over 15 years,
Absolutely.
from a time span, you're like, hey, it ain't too bad though. Right?
I
But
agree, but we can do better.
we can do better.
Yeah.
And I'm like, that woman, she needs to know what it feels like to hip hinge, to maintain a spinal curve throughout, to know when the bottom range is.
Absolutely. And what's interesting about that example is it would have been worse if it was a fusion,
It would, I believe it for sure.
right? Because that
here-
L5S1 was fused and not moving at all. The fulcrum becomes 4-5. It just comes right over.
And so you can confirm or add to this. From my experience with fusions, the problem is now that area is bolted stuck. It is bolted stuck forever. And if you still have pain in that area, you cannot move yourself free from it. And then now you're in pain management, which is, my opinion, most of them, the armpit of healthcare.
It
Armpit.
is certainly cyclical and unfortunately can get very ugly.
There are some good. Now I've made some posts about that.
Yeah.
And I have had different pain clinics reach out to me, and I've spoken with them. I go, oh, you are amongst one of the better. There is probably a top 5% that props up.
But it's cyclical. Unfortunately, patients just live in pain management clinics and get injection after injection, ketamine boot camps, all these things. It's not solving the problem.
Right.
And so, we mentioned quickly about bracing. I am so against bracing.
Bracing is in a back brace?
A back brace.
Oh, you're against it?
Against it. Why? Why? Because I think that if you're bracing, you're artificially taking away from those micro movements and taking away, unless you're focusing on you want to brace to isolate something else, that's different. That's an actual therapy. But if you just go to the gym and you put on a brace because you think you can lift more, to me, you're not developing that core strength because you just braced it out. You just took it out of the equation. If you need to brace, in my opinion, your biomechanics are disrupted and need to be fixed.
Because that is against the medical model is restrictive. So the back brace, and plus, hey, they bill out, they get $700 for a brace that costs them $30.
I don't remember. It's been over a decade, maybe a decade and a half that I've ever even sent a brace home with a patient. I just don't believe in it. Now, I'm at risk though, because if I send a patient home without a brace, and again, I know people that do, even in the motion preservation space, if I send people home without a brace and a brace is designed to keep you perfectly aligned, I am restricting a device that I've just put in that wants to move. Now, where can someone benefit from something like your program is how can I get them using the device properly? How can I get them moving?
The device.
Yes.
How do I get them to use the device properly? That is a really good way of putting it.
Because it's going, just like your patient that you just described, at some point, it's going to go where the body wants to go.
And if we take this, for example.
Yeah.
Okay. So, and please, if you,
please,
this is what, let's see, if they got this camera here. For example, this is the artificial disc. And so just really simply, people with disc issues, you wear out the disc because you're overflexing. Okay. And if you go to CrossFit and you move like that, you're going to speed up your process of that happening.
Yeah.
But now let's say you have a posterior left disc. Okay.
Mm-hmm.
Because the disc, where the disc compresses, it bulges opposite. This is the disc hydromechanics. That's
sure.
Okay. So if this disc, if you have left leg numbness, for example, left leg numbness, if we look at you, you're going to flex and you're going to tilt to the right, this direction, compressing the front right of the disc, bulging it out the back left of the disc. So to use this device properly would require them to learn to centralize the pressure upon the disc. Not always, but the way I describe it, it's a new return to center.
Absolutely.
A return to center. Our body's meant to go left and right.
Absolutely.
And the problems that exist with you guys, and likely, we don't want this. Let me see what pressure. I mean, I'm assuming, if someone goes in heavy flexion, they go back to CrossFit, they're going to wear out more of the anterior portion of this. Yeah. Have we seen long enough studies to see where this wears?
We do. We have 20, 30-year data, especially out of Europe, and over 1,000 peer-reviewed publication. It's not bad. So the cobalt, chrome, titanium end plates, they were titanium, now cobalt, chrome, there's actually great biointegration. So you actually do get a little microfusion, right, between the bone and the metal. But the question is whether this kind of thermoplastic, this ultra high molecular weight polyethylene core in the middle, if that wears. It certainly does wear. There's a wear profile, but all the FDA testing and all the long-term data testing says it's pretty similar to like a hip. So 20, 30 years, you see some wear. You certainly get some anterior wear there as it flexes forward, right?
Would that be the place that it...
Yeah, is what we've seen.
Makes sense because you're still flexing.
You're still flexing, yeah.
The back of it's probably like a brand new car tire. All the treads on it.
Yeah, so it's very, very common, but the question is whether it becomes clinically significant or not.
Yeah, right. Dang. You see, do you look at, in terms of the biomechanics side of things?
Yeah.
in regarding biomechanics, actually, you know what? Let's go back to what I hear from, and I'm sure you hear this too. This is one of those common ones. Disc bulge, disc herniation, even facet. The doctor said to stop squatting and deadlifting.
Yeah.
I hear that all the time. What do you have to say about that?
I never tell my patients to stop doing anything. It's just about doing it correctly. Yeah, I completely agree. I think, and this is where it becomes a little bit boutique and bougie, but I truly believe that unless there's a risk to your life or limb, you shouldn't have to adapt or change your quality of life or change your activities because of these problems. You just have to learn how to do these things correctly. And so, I'll pose the question right back at you. So let's say you have a patient who can't squat or deadlift. because of disc issues. And let's say you have an image, an MRI, degenerative disc disease. Not crazy. What's a degenerative disc? Black disc, which is, we can get into that because that's...
Black is whack, white is right.
Because I hate that. Because I don't think anybody should be operating on black discs.
Oh, jeez.
Okay. So,
I have 2 black discs.
Yeah, so do I have probably all of mine.
Huh.
Yeah, I mean, so let's say you have someone, black disc.
Are there people operating on black discs?
Of course.
Oh, my.
4551, black discs, maybe a little bit of loss of height. Maybe, you're at 20%, 30% loss.
What are they even doing in there? Go on.
And they're in pain. We can talk about a lot of reasons why that could potentially trigger pain. And they've been told by someone, no squats, no deadlifts, no jogging, no axial loading, right? We don't want axial trauma loaded. Okay. What would you do for that patient?
Pretty simple. Number one, I'm always going to root it back in a functional movement.
Sure.
Always.
Great.
Because I want to quantify this.
Yeah.
I'm going to take a look at them from the side view, and I'm going to take a look at their standing posture.
Okay.
Do they have a neutral pelvic position? Is there a protruding stomach that indicates a transverse abdominis weakness? Because core breathing is the only way that we can decompress our spine without hanging upside down. It literally improves every symptom, every diagnosis in the back.
I love it. I do like hanging upside down too, though, by the way.
It's awesome.
I love traction.
Yeah, it's great. It's just traction spine. That's nice.
Absolutely love it.
But that's why DRX 9000, that whole traction, they went bankrupt. I mean, one reason why is once you get done getting traction, you're back to your shitty position.
That's true. Absolutely.
It's not that the spine it's not that the spine is axially compressed. It is that it's compressed into flexion. It is compressed into right tilt. It's compressed into extension. It is specifically compressed.
Compressed incorrectly.
Compressed incorrectly.
Yeah, I agree.
So to answer your question, I'll look at their movement. And I'm saying, is this pain even coming from a disc, right? If this person does it, let's say they do a squat, and I see them moving into anterior and extension and sinking down, and then they come up. That to me seems like that might be more of an SI joint or facet joint issue. And so, but if this person goes down and there's no hip hinge, they fold into straight flexion. I go, okay, we have indications there's a disc. And if it's let's just say it's a sharp stab in the back if they get it during flexion, I'm indicated that this is likely not a full herniation yet, but this is maybe an annular tear that they're feeling on the outer third of the ring of the annulus.
Which doesn't need surgery.
Which doesn't need, what are they even going to do? Put a plug in it. And so there's a plug that you have. It's kind of cool.
Yeah.
So in that case, what I'm going to have them do is, because squatting and bending we have 7 functional movements our body does. Pushes, pulls, rotates, steps, lunges, squats. 6 of them, sorry. I think I got all of them. We have to be able to do those to have an active life. How else are you going to sit on a toilet?
Yeah.
How are you going to get off a chair? So I'm going to help them understand, well, always get them into breathing correctly, but then I'll get them on the ground, because that's where we start movements, on the ground. And I'll have them feel extension of their pelvis, feel extension of their rib cage if they fall into flexion.
Sure.
And then have them connect with those. That's why we do anatomy art. Connect with those muscles. And then eventually we stand, and then we move into a slow hinge, and we move into a slow squat as they're connecting, and they can see themselves from the side to maintain that spinal position.
Yeah.
Because we say rest. I agree that we should rest flexion for long enough, especially pre-herniation, for long enough for the body to build it's trying to repair itself, right? It's ultimately trying to, what is the tissue in the disc specifically is using? It's not like, it's like a fibroblast that makes a collagen almost. It's trying to create a dam.
Yeah. So it's a fibroblast collagen, and then there's also matrix metalloproteinases that work on destruction, repair. So, I mean, it exists, but what you're saying is, I think that every single patient before they have spine surgery should see someone like you, because it makes the most sense, because those small little disc degenerative stuff that we all have as we get older, just wear and tear.
It's on everybody.
That's not a surgical indication. I also love the comment about maybe it's not a disc, maybe it's a facet, because what we've seen, and this is very much in the motion preservation space, we talked a little bit about the TOPS, the artificial facet, is that when you have even a little bit of atypical disc mechanics, you load the facets more. Unless if you're stuck in flexion.
Well, you have atypical...
If you have atypical disc mechanics, if that natural shock absorber in your spine is not working, there's several things that can happen. But the most common is you're going to go over to kyphosis and flex.
Yep.
But if you try to pull yourself back and you're compensating, right, you're going to obviously have some back strain, back pain, because you're trying to overcompensate. But you're basically loading the facets more, because you're not having normal spinal mechanics. And when you load those facets more, the term in my world is spondylosis.
Sure. And
it's how one is related to the other. And it's one of the biggest problems we have. Is it the facets? Is it the disc? Is it the vertebral body itself? Is it the sinovertebral nerve? Is it the basovertebral nerve? Is there a epidural dural compression component? So is it the ligament? Ligament flavum can hypertrophy.
So you get very specific with those. I don't get that.
Yeah, but we get very specific trying to figure it out. And unless we're doing surgery, it may not matter, because if we can get someone into better alignment and better movement and better mechanics, if they're pain-free, it doesn't matter what the disc looks like on the MRI.
That's why I've only ordered like 2 MRIs in the last 9 years.
Treat the patient, not the picture.
And you said that too. And I want to talk about this because this is people. They go, I need an MRI. They think they need an MRI to find out what it is.
Yeah, I get it. I mean, there's in LA, there's Pronuvo scans where you get
I had one.
Me too. You get a whole body MRI because we want to, it's cool. We want to watch Netflix while they did it, right?
Yeah, I did. Watch stand-up comedy. I think Jerry Seinfeld.
Very good. But look, I mean, it's innate. It's human nature. We're curious. We want to know. Okay. I'm not against the idea of imaging to know. I'm against the idea of treating the image. We need to treat the patient, not the picture.
I think the interpretation of the image then, because what people do is they start to identify as if that's who they are. I have a disc herniation.
Yeah, that's true.
Have this thing.
Yeah.
I can't do this anymore. It becomes their identity. And to help them actually fix their body, it is so complex. The complexity is more dealing with what they have, the anxiety they have, the depression they have around this thing. I go, if I could just Men in Black and just zap them and get them to go, this is what's going on. Let's improve it.
Where's the camera? You are not your disc herniation.
No. And I put up I've done this on every region. One thing I'm terrible at is remembering like specific studies and researcher names. I'm terrible at it. But if you look at these studies, every area of the body, you take 40-year-olds with no pain, none. And you MRI, low back, shoulder, whatever, 80 to 97% of them have bulges, herniations, stenosis, and have no pain. Mm-hmm. And so that is the challenge why I go, man, that gets in the way. And I do think that I do believe, and I would love to go through some of these, it'd be like a quiz game almost maybe in the future where that I can accurately predict what an MRI will show based on movement plus age, plus I can actually predict what the MRI will show the pathology, not always what people experience as pain. So when I take people through movements, that's all I need to know based on their alignment, their posture, how they move throughout a range. I'm ultimately not caring even what it doesn't matter from my world what any of that even shows.
Sure.
Unless there's some huge risk factor.
Right. But some huge finding. I mean, MRIs, we talk about false positives and false negatives, right? There's so many false positives. So it has a very low specificity. Mm-hmm. But there aren't many false negatives. It's not there, it's not there. So it's very high sensitivity. But, what's fascinating about the idea of how many people, the prevalence in the population that have a finding on an MRI that's not symptomatic. The question is, why are some people symptomatic?
Do you think it is because of my current theory of that is that if someone has a disc herniation, they're not full herniation, not symptomatic. There is not a significance of inflammation around that area because we can push on a nerve gently without. But if someone is actively continuing, let's just say we use the word flexion. I'm really simplifying. It's just the most common. There's flexion combined with tilting, combined with rotation. There's combos. But for flexion. But if they're actively flexing and that disc is moving in and out in the body, it's the act of inflammation, which is why a cortisone shot can give them relief often.
Yeah. I think people tend to be in a hypercortisolemia, hyper-inflammatory state, especially today, more than ever. Stress, sleep habits, who knows what. We talked a little bit, sexual function, your intimacy, all of this plays in. And I think when you're on this cycle of cortisol stress, anxiety, I think that you're more prone to pain syndromes or a pain effect from something that other people are not.
Like a hypersensitivity.
A hypersensitivity of some sort. The part that scares me, and I've seen it a few times, thankfully not the majority, is when the body kind of fails to tell us, fails to say, where was pain? Why did the patient come in with a foot drop and can't move their foot anymore? Why is the nerve damaged and there was no signal? That's also scary. That's why I'm often concerned about the pain management route. Because if we keep masking pain, we keep giving steroid injections, we keep doing these things, the way that the body tells us there's a problem is pain.
It's taken away.
And now suddenly you don't know. We don't even know if the damage is being done.
And
I'd much rather send someone to you, no steroids, no pain pills.
I don't want any of that.
I mean, either. And you fix their biomechanics. And if they're still disabled and pain, okay, we know we have a problem.
Exactly. And because also pain, you know what it takes away? You know what this does? The cortisone shot and whatever anti-inflammatory pill they take, they have all the intentions of working. Pain is an amazing motivator, and I love it.
Yeah.
And when it's taken away, their motivation usually goes down with it. They have all these great plans. They're going to do something.
Yeah.
Oh, the cortisone shot worked. Back into these shitty patterns, but they can't feel that it is, theoretically for me, my hypothesis, it is accelerating degeneration.
Sure, I agree.
Because they're not getting signals that anything's wrong.
That they need to correct.
They need to correct.
Yeah, I agree.
I think pain is actually a great thing. Pain is like a signal. And you talk about, this is the first thing I tell my clients is, there's usually an order. There's usually there's signs, things we see, right? If we see that we're flexing from our back, that is a sign that there may be some problems in that path forward.
Yeah.
In terms of their body.
Sure.
And then once the signs, then it gets to symptoms, which might be subtle at first. Clicking, weird pain every now and again, and then eventually full-blown symptoms. I'm ultimately trying to catch them at the sign. I'm trying to catch them before the sign. If we can get this into kids' school and get people moving right.
Yeah, I think that, again, not to belabor the point, but what you're doing ultimately doesn't, and we talked about it before, it doesn't take away from the business. I actually think it helps.
That's really amazing.
I really believe what you're doing will prevent a lot of unnecessary surgeries. And if someone does need surgery, they'll be better off afterwards.
They will be better off.
Because what we're doing is very similar in many ways. You're working on biomechanics and body mechanics and alignment and movement, and you're doing it before they get to me, or maybe afterwards. And what I'm doing is trying to do the same thing, but I'm very much relying on someone's movement and body mechanics to use the disc or use something that preserves motion.
Use it.
Because the fusion takes away from all of that. And what we've noticed in fusion is, imagine, I use this analogy a lot, but imagine a car and you have 4 shock absorbers on a car. One shock blows. You fuse, it's basically fused, right?
That's
One
right.
shock blows.
That's a good way to look at it.
Okay, so it's not working, but you can still drive the car. What happens to the other 3 shocks? When there's that lack of symmetry and lack of mechanics and movement, they're going to wear and tear faster.
What happens if you hit a pothole with that broken one?
Even worse, right? So, and we've seen this. We've had some disasters where someone can have a fused neck, they trip and fall, and it's like a moment arm, right? And so the level above or below snaps, and then you're paralyzed.
It is right.
So we've seen disasters because especially a rigid fusion that's long, chronic, healed, matured, essentially dangerous.
Because you have no elasticity of the spine to accelerate anything.
None.
If anything, the moment arm increases acceleration at the end point.
Exactly.
Holy shit, I never thought about that.
So there's so many things that are wrong about the bad F word, fusion, right? That we're talking about, what you and I are doing at different ends of the spectrum are really, it's so similar. And I think that what I'm excited about is delving into I think my patients going to you afterwards is an easy one. How do we delve into where your method, when is the decision that it's not enough?
Let's talk about that.
Yeah, how long, we talked a little bit about time, we don't know the answer, but how long do you want to work with a patient who maybe has a forward tilt and maybe what we think is some discogenic pain? Maybe. How long are you going to work? And I'm not putting you on the spot. I really don't even know the answer, but how long would you feel comfortable working with them? They have imaging findings that are, and we're talking about a bougie, more boutique, safer than ever before, highly functional. I've got many professional athletes banging on these, discs. What's your criteria?
This is good.
Yeah.
Okay. So, and I do have a question for you after this too, because something I've wanted to know, and I don't know if you do know.
Yeah.
Let's just, like I said, we'll talk about simplicity. Let's say somebody has SI joint, facet joint.
Sure.
They're in hyperextension.
Okay.
It's obvious. We do a simple movement screen, standing, side view squat, side view lunge, face on lunge, because we're looking for leveling.
Okay.
We're looking for specifically of the pelvis and rib cage. We're looking for combination of flexion extension, rotation, and tilting.
Yeah.
and how these two blocks sit on each other. The pelvic block does all the same things the rib block does. Okay, so we look at that assessment. And we link it back. Does that link up with this SI facet joint? Yes. Let's say yes, it does.
Okay.
We take an MRI of the back or an X-ray. We see some spondylosis of L5. We see some mild this and that. This person, to me, when they're able to, from a measurement standpoint, when they're able to perform this squat and this lunge at a high speed under control of that movement, and they're aware of it. Awareness is the hard thing to measure. This is the person. I did a 10-day silent meditation retreat, and
you told me, yeah.
And what Buddha said, he goes, awareness is the ultimate yardstick of progress. And so being aware is what people do in their everyday life. So let's say that we assume that they go, I have awareness now. My breathing's better. My mechanics are better. Here's my squat. Here's my lunge.
Okay.
Great. Now the question is this, is the body, and this is heavily taught in my chiropractic education, the body is a self-healing organism. So what I don't know is, like, will that bone remodel whenever there is not stress placed upon? I mean, the skeletal system's replaced every couple of years. Will that bone remodel? And if there is, let's just say maybe there was a little stenotic nick in there, a little nerve. How long, when the body is in alignment, how long does the body need, based on age, of course, to heal? That's what I don't know.
Right.
Do you like?
I don't know.
Right.
No, we don't know.
And then you try to put a time frame on it, because I do see it all the time, is that when mechanics are restored, often the pain goes with it, right?
Sure.
So mechanics, confidence goes up. It takes 90 days for us. So 90 days of people working is what our key number is. In that time frame, yes. But then afterwards, there should be a steady healing on that one. But after they can restore mechanics from that, which, because we're not talking much here. We're talking about, if you're doing this and focusing on this, you're talking about 90 good solid days in there.
Yeah.
Solid.
Not much to ask.
That's a low end. That's a C- student. Okay, you passed. And then on top of that, so that 90-day period, showing that speed, showing that, and if they're just like, after, let's just say 2 more months went by, 5 months, and they're like, that pain is getting worse down here. I feel it, I feel more, maybe it's moved down to my toes, radiological, and their movement mechanics seem solid still. Then I would be like,
okay. So that's sensible to me. That is sensible. We haven't waited to the point where they've lost function.
Right.
Their movement mechanics, you've taught them, are better. You don't think that it's still a problem.
Right. And
they have progressive symptoms. That's great. I mean, that to me is a safe practice, and that makes sense.
What would you say about the, and I think with disc is, with the disc would be a similar approach. It is going to be, can they demonstrate holding that natural extension?
Yeah. I think the thing about, you bring up an interesting point. Disc, nerve, facet, yes, it's all part of the spine, but these are different processes and different pathologies, and they may need different fixes.
It's opposite. The joint fix is opposite of the disc.
Completely
it's
agree.
Two separate paths.
And probably different length of time required for healing or restoration of movement and mechanics. They're different surgical approaches, right? So these are, the only thing that's not a different surgical approach, ironically, is a fusion. Fusion just takes care of everything, fuses everything, right? It's circumferential fusion. But the nice thing about motion preservation in your world and my world is that we actually can be targeted. We can isolate the problem.
So with motion preservation, you mean you can isolate the problem as in?
The disc, the facet, the nerve. So we can specifically isolate the problem. Similar to what you're saying is that you would handle a discogenic versus facetogenic versus nerve versus sequestered disc problem similarly or differently with different body mechanics. You're focusing on specific biomechanic pathology and specific fixes. So are we. And that's what's unique about, I think, you and I, as opposed to the old mentality of just fuse it and take away the problem altogether.
And in my world, generality, which yours is probably fusion, in my world, generality is going to be, I do know of some great physical therapists out there. But generally speaking, I volunteer teach at a couple PT schools. And the one I teach at, 0 hours of movement rehab. None.
Yeah.
In a doctorate of PT.
I don't get it.
I don't get it either. And the point is like from your perspective, you're like, hey, you know what? You say the person does black disc, right? They have pain.
Yeah.
Where do you even send them?
That's the problem.
That's the problem.
Yeah.
I know it's a problem for me too right now.
It's a huge problem because the standard answer is pain management PT.
Pain management PT.
But I don't know. But I don't actually know what those two are going to do with that patient.
I'll tell you what the general PT is going to do with them. The general PT believes that strength and mobility and exercises fixes pain. And so they will take these people through cat cows, bird dogs, thinking that the reps get them better. Thinking that by more flexibility gets them better. These are these super general.
It's a huge generalization.
Thinking that, not training though. Specifically, do you know the reason why, the purpose of doing a cat cow? Like, if we're here, really the purpose of this position. So we're doing a cat cow. What is the actual purpose? It's aside from, increased circulation, blah, blah, blah. What would you say this?
You're obviously hyperextending and hyperflexing. So we're talking about potential self-lubrication, endorphin, facet, disc anatomy. But honestly, other than looking kind of funny, I have no idea.
When they stand up, they're going to go right back into pattern.
It doesn't change anything when you're weight bearing.
But if they're down there and they have disc issues, these people with disc, they're going to be right here. So truly the purpose of a cat cow is we're unloading the disc.
Sure.
Great. We got now all of our weight distributed into 4 contact points. Now we can move the body, the pelvis, with less pain and in more control because it's not weight load into extension.
Yeah, so you're gonna take off the axial load from the disc, load the facets, but you're not weight bearing, so it's easier to do.
Yeah, I wouldn't say load facet. I say teach them to use their QLs, teach them to use their rerectors. And same with the rib cage, which is a separate unit.
Okay.
And then whenever that person now stands up, it's to now reconnect that same position that they were on the ground.
Does that happen?
If they consciously understand what the hell the point is they're trying to do.
Okay.
If they understand the long term, which is my job is to restore the alignment and mechanics to their 7 functional movements, starting with the biggest deficit that's most related.
Yeah.
But the answer is they don't. Because in PT, they'll cat cow, get the sets, get the reps, get the bird dogs.
Sure.
But it will. Like if you do those, for example, bird dogs, and that person stands up, their erectors are temporarily on.
Right, sure.
So they could technically do this every day and have this unbeknownst to them muscle tone that's holding them there. And then and it goes back. But if you teach people, and I see it all the time, it's my success stories is whenever they connect and aware of it, that's why the awareness about why they're doing. But this is what you don't get in PT.
Yeah.
Massage it. And that's why the whole PT, they're against me too. They're ostracizing me. Chiro's ostracizing me. PT's ostracizing me.
You can be ostracized together. It's okay.
Are you?
I'm always ostracized by all the stuff that I'm doing. I started a clinical trial. I don't think we've ever talked, but we talked about maybe briefly on the phone, but I started a clinical trial. We were the first in the United States to do this at all, where we actually put an artificial disc in the front of the spine and put an artificial facet in the back of the spine. We called it the 360-degree arthroplasty trial. And that's a lot of surgery. That's the antithesis of your world for sure, right? But the idea is that there were some patients that had such significant mechanical instability or spondylolisthesis with severe stenosis, neurogenic claudication, nerve issues, that the only solution surgically was, at one point, people thought we could just get away with a simple decompression. But there was actually a very famous study published in the New England Journal of Medicine called the SLIP trial. SLIP, fancy, good, very smart name. And
SLIP trial for like spondy?
For spondy, exactly. And there's a SLIP 1, there's a SLIP 2. And there was really an inappropriate level of crossover, meaning that the patients that got just the simple decompression progressed with their SLIP, progressed with their spondy.
When you say simple decompression, you mean
like a laminectomy, just a laminectomy.
Laminectomy.
Without the fusion. The fusion was the other arm. So the crossover was that they needed the fusion because the fusion was the only thing that prevented the SLIP from getting worse. So the decompression was done for the neurogenic symptoms, the laminectomy, right? They just took off the ligament in the back, a little bit of the lamina to open up the nerve. usually that would be sufficient. But if someone slipped or their facets were not stable enough or the disc was so diseased, there was no stability on that shear stress forward.
Because you got one pedicle left.
Exactly. You got no functional stabilizers left. And so the problem was that was considered unacceptable. So most people, when you have a pretty high grade spondy, a pretty high grade slip, diseased facets, no disc, the answer has always been fusion. Sad thing for us, so you ask why I was ostracized a little bit. I mean, it's in jest because there's a lot of posts on LinkedIn about, oh, this guy's crazy. And then I got a whole bunch of people defending me. And then this is the kind of, so it's, it's fine. It's good. And I always answer all these skeptics, especially overseas. I'm like, I mean, we can stop with the name calling. Let's have an academic discussion about it. We're running a formal clinical trial with ethics approval, with an oversight committee. We're doing it right. Yes, it's experimental. But the idea was if this patient has failed everything, has neurogenic problems, and is the only option has been up until now a fusion because they have so much problem anteriorly in the front and behind.
Because they'll decompress it, shift it back, line them up,
and fuse.
Screw it.
And screw it. Boom, right? So if that's been the only option, especially if I've had patients in their 20s, 30s, and 40s with this condition.
Oh, yeah.
And if that's the only option, there has to be something better. And when the TOPS was finally FDA approved, and we were part of the original FDA trials 7-8 years ago, we're like, well, wait a second. One of the reasons you can't put in an artificial facet is when there's an inadequate disc space, because this requires the disc to work. You must have adequate disc space. For the facet replacement, the current facet replacement on the market to work, you need an adequate functioning disc because it lies on your disc.
And because you also have a spacer here, so you're saying it would just hinge forward without it? It would just hinge?
I mean, the question is not only would it hinge, is that let's say if your disc was not adequate, how would you flex? How would this allow flexion at the disc space if there's no disc space? So you'd have restricted, it'd be like, why did I put in an artificial facet when I can't move at the disc? You'd have two conflicting forces.
Right, because you're looking for a cushion anterior and posterior, and the anterior cushion is gone.
Exactly.
So it's like bone, and then you've got a posterior.
Right. So that doesn't make sense. If anything, I think that will cause more pain when you have conflicting forces, right? Fusion motion, when that happens, is a real problem. And so the trial and why there was some scrutiny is, and it's ongoing and the success rate has been incredible, is let's take that artificial disc. If the exclusion criteria is I can't give you an artificial facet because you have an inadequate disc, let's give you a disc.
Right.
So let's give you an artificial disc, get some adequate disc height, some adequate space, and now let's put in the artificial facet, decompress your nerves, open everything up so you have motion from behind and motion from the back, from the front.
That makes sense for a 360 standpoint.
360 standpoint, right? And so the idea was, well, how do these things work together? It's never been tested together. We're doing I'm working with the Cleveland Clinic.
This is the first time it's ever been a double?
Yes.
Wow.
And so we started this trial, and we have about 25 patients enrolled over 2 years. And it's an expensive trial because we don't have funding from anyone. So that's been one of the limiting factors, unfortunately.
Who funds it?
Patients, us, we all help it.
Really?
Help it. That's one of the limiting factors is unfortunately finance.
Why can't you get grants for that?
Because it's considered heresy. I mean, the standard of care for this condition has been a 360 fusion.
Right.
And so we're using two FDA-approved devices together in an off-label way. So we're using it with the Cleveland Clinic. We're doing some biomechanics studies simultaneously. And I can tell you, and we have a special, the Israelis who invented the tops and the back, they came up with this calibration device so we can position them together so they work together. So we're trying to do it right. And I can tell you that and this is, again, 2.5 years of data on a small subset of patients, but I have 30-year-olds who are kickboxing, skiing, running, jogging, who all data has shown stability and maintained motion at that segment without any significant early adjacent segment disease, which we would have seen in fusions. Because all these patients, unless they found you and you miraculously helped them, and some of these conditions are too far for anything. You patients who are really dire straits. You're in dire straits, right? So these are patients who would otherwise have been fused. The early data shows something fascinating, that we are able to stabilize the spondylolisthesis, stabilize the slip while preserving motion.
Stabilize the slip.
While preserving motion. The concept of, if I say the word stabilize, that always meant fusion. Stabilizing means fusion.
Because now, or at least from this perspective, now, in terms of like the pedicles, you've basically given them an artificial pedicle, one that they
Yeah,
previously
the pedicles,
fractured.
The pedicle, yeah, the pars, the facets are completely gone because yes, there's a fracture and incompetent facet that allowed the slip to happen in the first place. The pedicle screws are there just as anchors because there's no bar connecting these, which gives the tops its ability to move, right? And so I don't know if this is the answer. I know that the alternative, if it was me, I would want that, even as an experimental trial compared to a 360 fusion.
So I will, with high confidence, accurately predict the long-term outcome based on this.
Sure.
Depending on the size of the disc used. With every single person I've ever seen with spondylolisthesis. So with you guys, unless it was traumatic, which is what, 5% of the time. Most of the time, high school sport.
Yes.
Now, I have a theory. Now, I haven't seen any data on this one, but hyperextension is what's increasing the stress on not only the facet, but on the pars.
Absolutely.
My belief is that this adolescent entered the sport in hyperextension. In the repeated hyperextension, maybe football. We know that hyperextension fractures.
I think there probably is data on that. That makes complete sense.
We know that hyperextension fractures it, but people, I think they try to relate it with like one injury once. I'm like, no, this thing is a stress fracture.
Repeated stress fractures.
So this person, whether they're 20, 40, or 50 years old, when they see me with spondylolisthesis, absolute massive anterior tilt hyperextension, every one of them, everyone's in hyperextension. And the reason is simple, right? That pars fractures as it slips. Now we flip into extension. So this person particularly that you've done this on, when they're done with the surgery, they will remain in hyperextension.
Agreed.
Unless obviously you can adjust, but even then, so their hyperextension behaviors, their squatting, their running will remain. And now what we're talking is stress, like different stress on more joint for spondylolisthesis.
Fascinating. And this may be a little too technical, but fascinating you just mentioned this because so true that when we were starting to do this surgery, we changed the bed and the positioning of the patient because we noticed that the patient was going into hyperextension. Every single
massive, almost double the normal amount.
Absolutely. And we had to actually change the position. I mean, I remember the first few cases where it's too late to change the bed. The patient was asleep already positioned. We had a sheet and we underneath the patient, I pulled the patient up from the abdomen to flex them.
Right.
Before we locked this down. Before we locked it down. Because it absolutely hyperextension is a problem. Now let's this is a great segue because our mutual friend Natalie. Who said we can talk about her.
Wait, before we do that. So my prediction is that the failure point is going to be at this disc, at this artificial here, because they're still going to have so much compression and lateral tilting that this is going to be the weak point on spondy, unless this person learns to pull their spine out of extension.
Which is, again, great opportunity to collaborate with these cases.
We need to run some research on this.
We should. I mean, I have one of my patients. He had a 2-level artificial disc and a 1-level here where he did a 360. He's a former catcher, baseball player, professional. And his standing x-rays to me look like he's still in pretty significant hyperextension. And he went from being kyphosed, spondied, degenerated, and every part of his spine was compensating by hyperextending. Right? He was trying to create more lordosis where he was falling forward, literally shear stress falling forward. And we were able to correct him beautifully into what looks like a great lordosis, but I'm almost certain he is chronically hyperextended.
All we have to do then is put this data in, have you do side squat, front view, bend, and just look at a couple different angles to determine that. But even with the technology that's out there. But spondy is, I had one more thing about spondy. Spondy is...
So when he's saying spondylolisthesis, it's just a slip. It's a mechanical slip. And you're mentioning stress fractures. There are other types. You can have spondy when you're 60 or 80 years old. That's degenerative. There's all kinds of
extension issues still.
I'm not. Sure.
Right. But what I was saying was that this hyperextension of I had something too. We'll keep going. We'll keep going.
Yeah. But I mean, that's great. I mean, I love the idea of you trying to predict where this type of construct will fail because no one's done this construct.
I would love to come in there as like a biomechanicist and help with these things. Man, we could, we would just need spondy. We would need to, well, obviously fix their mechanics, but obviously if you can improve the hardware to match the likelihood of the failure point on it.
So that's the segue, right? The question here is, what do you have at your disposal to get patients into proper mechanics and alignment? And what do I have at my disposal to get people into proper mechanics and alignment that doesn't involve fusion. Because like we said, fusion gets you into perfect alignment, textbook alignment.
Perfect alignment at 2 vertebra segments.
That completely destroys the rest of your spinal anatomy, your global anatomy, your movement, your overall alignment. Agreed. And so one of the things that you had brought up, and I think you posted it about Natalie, is when we did her artificial disc, I mean, she was bone on bone. She was collapsed. She's tried what we determined to be everything and anything. We can argue. We'll start the body slam.
I roll full force.
Fine. That's fine. We can box and body slam each other in a second. But
no, I wouldn't know. You know why? Is because I would have put Natalie, I love her, but I put her in a stubborn, closed-minded position to not be willing to do anything else. So I would almost, because there also is a mindset component on these surgeries.
There's always a mindset. But she would argue, and I'm going to advocate for my patient, that she tried a lot and she's very active and she was very much bone on bone. And we don't have the technology yet, which I would love, is let's inject a stem cell into that disc space. And a lot of my patients have tried stem cells. Let's inject a stem cell into that disc space that magically regrows your disc.
Is there anything that is on the disc level yet?
There is a trial currently being done that is there's a disco seal to seal a disc. There's also one where you actually kind of inject an artificial disc, kind of allograft, if you will, true artificial implant membrane into the disc space. None of this has materialized as anything yet. There's no data. And stem cells to regrow discs, there's no data. It doesn't work. We've had stem cells from overseas. People go overseas to inject some stem cells. I've seen it eat away the entire spine. We have to reconstruct the entire spine. So I'm not against stem cells, exosomes, peptides, PRP. Love it. Think that's the future. But we don't know yet, and we can't control these things yet. Can PRP lubricate those facet joints and buy you some time? Sure.
But if somebody is
bone on bone,
if they are chronically flexed, they walk like that, they bend like that, they move like that, how would they expect anytime a stem cell to be able to regrow tissue at a faster rate than they are destroying it?
I don't know how to be. I don't know how there would be that expectation. It doesn't exist. I mean,
I guess expectations from other regions of the body.
I guess, but here's the thing. And I love you saying maybe she didn't do it all. Natalie's case was fascinating to me because she was so bone on bone. And we can talk a little bit about your criticisms of the disc and the alignment and the hyperextension or lordosis. And that's great to get into because I'm going to argue her pre-op pelvic incidence lordosis match, and we can talk about mismatches.
I'd love to see what you found specifically with that. Are you still looking at pulling those up?
Yeah. So, I mean, I don't have the number of what her preoperative lumbar lordosis and pelvic incidence was. But the idea was we're certainly limited because I put the smallest disc height in her.
Right.
And so I couldn't have put her into a position of less lordosis.
Right.
Whether or not I got it perfectly right, it was the smallest. Whether I got it right and it matched her pelvic incidence, lumbar lordosis, we talk about mismatch within 10 degrees. Hard to say because it was my only option.
Could you shave off a little of the superior aspect of that bone?
Great question. And now super technical because it's surgically nuanced, but I think that's a great question. So yes, you could do that. But if you do that, you then run the risk of subsidence of the implant.
The solidity of that
and the implant will plow into the disc, into the vertebral body.
That has been a problem with some of these.
Absolutely.
Sinking into the bone.
And if that happens, you're really in trouble. Because then you have fusion as your backup and only backup. So here's my question, and this is an honest question.
Yeah.
And I'm going to put you on the spot.
Please.
And I'm using Natalie as an example. I love you, Natalie. I'm sorry, but I'm using an example. I still think she made the right choice. She thinks she makes the right choice. But you're saying maybe she didn't do, you were eye roll, noted. If someone is so bone on bone, there's no disc left.
Right.
It's so destroyed. What movement mechanics, what improvement can you offer them that will fix this? If we believe that disc, that bone on bone, the lack of disc is the pain source.
Well, biomechanically speaking, the only muscles that would create there's two sets of muscles that would create that set of leverage. Number one, you have actual core breathing, where pulling the diaphragm down and pulling the transverse in to create intra-abdominal pressure, which will push up on the rib cage and to decompress.
Okay.
That's number one.
Yep.
Number two.
But doesn't regrow the disc.
No, doesn't regrow the disc.
Okay.
Number two, you have the multifidi and the erector specifically around the site, the lowest ones, which are surprisingly difficult to target unless you know how to do them.
Yeah.
It is like, I'd love to take you through some movements.
Love
like we can target literally L5 erectors. I can move up the chain with those.
As long as you don't get too touchy-feely with me.
We see based on conversation over here. Not opposed to it.
All good. You can touch my erectors anytime you want.
Right?
All right.
Yeah. So from a biomechanical standpoint, that is between the transverse abdominis and the erectors and multifidi. That is and also to maintain that. It's not just like a static position. Whenever that person bends, they have to keep the awareness to keep that wedge open.
Sure.
Throughout the movement. Like there is an awareness that has to happen on that one. But you're right. It doesn't solve, it's still bone on bone. So then the question becomes on that, like if we MRI, how many people are bone on bone and living with no pain?
I mean, that's the that's the big enigma, right? Where's the transition point? Where's that inflection point of people who have the same picture as Natalie?
Right.
Same picture as Max, same picture of all these people who are out there talking about what they had done and their images. Where is that inflection point where some people are symptomatic or not? I don't know the answer to that.
I don't either. I'm actually more blown away that people don't feel more pain. Basically.
Yeah. Oh, I've seen pictures. I'm like, I don't even know how you're walking.
You've heard of that book? It's John Sarnos that it's called Healing Back Pain. It's like a 1970s.
No.
This book is thank you. It is he gets into a theory, and I forget, I read it a while ago, but there is millions of people that attribute their instant pain relief from the teachings of this book. And I go, because even my head and mechanics, I go, how the mechanics are screwed up.
Yeah.
What you found a way to override your system.
But that's also interesting. There are people that will override the system and not using your techniques or my techniques, right?
Yeah.
I mean, there's a secret sauce. There's this holy grail of, you talked about your Buddhist meditations, kind of silent retreat. I mean, the brain is extremely powerful. We know we can trick it. We know we can do things called neuromodulation. We can put frequency generators on the spinal cord that blocks your pain. I mean,
right.
We can change the way you perceive pain.
But is that what we want? Like, I'd rather be, I was
going to say the same thing. I'd like the mechanics to be better.
Too. Because I just saw it. I'm like, okay, even if people don't, my challenge is that, well, let's just say we see somebody walking we'll just keep with the pelvic tilt. She'll say we have a pelvic extension again. I go, man, they may not feel it, but their footsteps are degenerating at a faster rate than everything else. And if they don't feel it, where is the motivation to address and change it? Sure. And so, maybe I look at the body as more of this, like I'm looking for this equal and balanced pressure distribution to allow the structural wear of our body to be equal and as equal and as slow as possible.
Yeah. But I hear this all the time. I can't do what you're asking me to do because I'm in pain. So how do you get someone through that?
That's a good question. And that is where, that's a really good question. For most of the time, the movements that they're doing that causes pain aren't the right movements.
Interesting. So that's amazing. That's really interesting to think about because it's common sense, but people are not thinking about that.
They're not the right movements to do. And I guess we can just talk about the baseline of those first.
Sure.
The people who have, let's say they have actually a disc herniation. These people ultimately, by focusing strictly on powerful core breathing, and I don't want anyone to undermine the power of core breathing. I dismissed it up until 10 years ago. And I literally should be sued for malpractice, for negligence, for not helping people with this before. It is quite possibly the most powerful tool that every person out there with back pain should master is core. It's the only natural decompressor of your spine. When people talk about the core, there's 12 muscles in the core: transverse abdominis, diaphragm, pelvic floor, erectors, QL, obliques, rectus abdominis. And people think of the core as in the rectus, but this powerful core breathing is a synchronized activation of almost all of those core muscles in the right firing order to decompress the spine. Everybody can core breathe without pain, as long as your body's in the right position to do so. Hands and knees on their back. It is my buddy, William. He re-herniated a disc, and he couldn't move for days. And I was on the phone with him at 5 o'clock in the morning. His girlfriend called me just a month ago. We did core breathing for 10 minutes, and he goes, I am so much better from that. It is so powerful.
Amazing.
Of a tool. And I'd love to go through it with you.
Yeah.
I've evolved it from, I'm a free diver. So I've done a 5.5 minute breath hold, done with Wim Hof. I've got combined what I've known to this. But so you can always core breathe. I just don't want nobody to undermine how important it is.
It's interesting. I wonder if this is antithetical to what you're doing. And I wonder if we're doing it wrong, because often we block, especially around surgery. We'll do transversalis abdominal blocks. We'll do ESP, erector blocks. And we do that because we want people to recover from surgery and get up and move faster.
Oh, interesting.
Yeah. And I wonder, these blocks don't last more than a day or two, but I wonder, it's a balance, but I wonder if our motivation to get people up and moving by doing these blocks doesn't necessarily get them up and moving properly or correctly. I wonder if you can core breathe when a large majority of your core is blocked.
No.
And I wonder how important it is to do that. Right.
Not with TVA.
Right.
It blows out like a tire this way.
So I wonder how important it is to do that in the first 24, 48 hours, and if we should be opting to not block.
I think
obviate the block and treat and do it differently.
I think that would be a surgical thing, because from a functional standpoint, they're going to fall right back into their old patterns when it wears off anyways.
Right. That's also true. It's just something I thought about, because we do it routinely to get people home, to make it more boutique, to make it more outpatient, to get people up and moving initially, and then it wears off.
But if you core breathe for 5 to 7 minutes straight, powerful, maybe we should do a little session on core breathing.
Yeah, let's do it.
Want to do a little session?
Yeah.
Okay, let's do it. Let's do a little core breathing session. Let's have, Matt, you can do it too? All right. Let's have you stand up.
All right.
Yak it off.
Let's do it.
And everyone at home, do this as well, because but before we get to the core breathing aspect, the most simple way I've been able to describe it is you must strengthen and mobilize your body in the opposite direction of the misalignment. So if this person is in, let's say they have a posterior left disc, that means they're going to be likely flexion with a high right hip. Okay. And so if they're on their hands and knees and they're pulling only their left hip up, they're reversing that in a decompressed way.
Sure.
But so it is specific about these people. I'm in pain no matter what. We get into it. The movements that they can do are the ones that they need to do, but their body doesn't know how to do them yet. All right.
That makes sense.
So let's do some core breathing. Let's take a look at let's go hand here. Let's take a look at your diaphragm breaths. Look at this. All the way in. All the way out. This time, no movement of the shoulders at all. This is all still, all diaphragm. Go ahead. Right? And all the way out. All you have to do is test your patience on this. 90% can't do what you're doing right now. They're going to go with their shoulders. Good. Now all the way out. More. Good. Now big inhale all the way. Now powerful exhale like a snake. All the way, all the way, all the way, all the way. While you're keeping a little spinal extension. Good. All the way in again. Let the stomach come out more. That was too much chest. Force it out. Yeah. You felt it?
I did.
Force it out. Good. Start over. All the way. More power. Big inhale. Good. Scaps in position too. Pull the scaps back right to here. Now powerful exhale. Good. Now you're getting it all the way out. All the way. More. There. More. Good. All the way in again. Good. Force it all the way out. All the way. Force. Now hold your stomach. Now relax everything. Yeah. Now let your stomach just stick out like you're pregnant. Now pull it in tight. Snap. Here's the snap. Like this. Snap. Snap. Good. Couple more of those. Okay, I want to get the movement. Snap. But while you're snapping, though, keep the natural extension.
Got it.
Okay?
Oh, see, I'm trying to...
You're flexion dominant.
Yeah, I'm flexion dominant.
Right.
See how I'm doing?
Yep, I do. That's a flexion dominance right there. Do this. Lift your tailbone up. Hold the tail. Feel the erector right here?
I do.
Hold that erector and I'll snap in slow. Better.
Interesting.
Again. Good. Snap in tight. Hold it. Hold it. Now add a little extension so you can really feel extension with the snap. Co-contraction.
Got it.
Now we have co-contraction. Hold it right there. Excellent. Excellent. Snap again. Flexion out. Stomach out of me. Snap it back. Now you're going to hold the snap in and don't let it go.
Okay.
Do not let the snap go. Okay. Now, diaphragm breath again, and you're going to feel expansion through here. Big diaphragm in. Good. Keep the snap. Now full exhale and snap further. Good. Hold that snap in super tight. Big diaphragm breath all the way in, all of it. Good. Re-snap it. Now force the exhale, snap and extend. Snap and extend, snap and extend, snap and extend, snap and extend. Good. Again, keep the snap. Big inhale. Good. Now force that exhale. Now let's take it to something that will function. Okay, so we go, how is this so important?
Yeah.
The most PSIs in your midsection are if you're snapping in your diaphragm, right? You've got the diaphragm moving down.
Yeah.
We didn't get into pelvic floor, but you get the pelvic floor lifting up. You create the most PSIs through here,
Sure.
which is going to give you the most decompression of the spine, the most spinal protection.
Yeah.
Now let's sync it up with the movement. So the movement is when I get people like introducing them to, let's say we have somebody introducing them to movement. It's going to be a snap, inhale, hold the breath. So this is the basic version to hold the compression through the lift. Okay, so let's work on a few reps now. What do we got? This thing's better. What is this thing? Great.
I love the props.
Deadlift.
All right.
So let's see you dynamically hold that snap as you're doing something like a bend.
Okay.
Okay. So nice tall. Definitely seem like some flexion dominance so far.
Yeah. It doesn't surprise me because I'm a surgeon.
Which, right.
It doesn't surprise me.
But we shouldn't let the profession
No.
determine the fate of our future.
We should correct it.
We should
I agree.
fix our
I
shit.
absolutely
We
agree.
should fix our shit.
I'm the first one to sign up. I love it.
Okay. So now let's work on the snap. Big snap. Good. Inhale. Big inhale. Hold the snap. Add a little extension through the tailbone up. Hold the breath. Hinge down all the way down. Okay. All the way up now. Keep the breath in. Let's take the snap at the bottom. Good. Now all the way up. Powerful exhale at the top. Powerful. Oh man, it's so flexion dominant. We got you. Okay. Okay. Again.
I didn't know I was coming for a free therapy.
Snap.
Great.
Got you. Well, I'll get a free surgery.
Done.
Yeah. Good. No, start over. We got to do the breath at the top.
All right.
Remember, we're compressing our core through breath because as we get into this lever arm here, our spinal, compression, extension starts to increase. So we're prepping for that by compressing midsection.
Okay.
Snap. Tailbone up. Inhale, big inhale. Re-snap. Hold the snap. Go down slow, hinge down slow. Snap, snap. Hold the snap in tight. Hold the breath, hold the breath, hold the breath, hold the breath, hold the breath. Now hold the breath and come all the way up, but hold the breath, hold the breath. Now powerful out. Now that's level 1. Now level 2 on a lightweight. Let's say someone's just lifting. You're going to powerfully exhale on the ascent.
Good.
Snap. Good. Powerful. Nice. Nice. Again, big inhale. Snap. All the way down. Good. All the way down. Powerful and nice. Every rep turns into a core exercise. Real core strength.
Completely different than what you'd be taught by a personal trainer if you could.
Right? So this is true. This is now people go, I don't know if it's safe. I'm like, has the doctor given you clearance to breathe oxygen? Then you can core breathe. So the last one is going to be speed. So every rep, I guess we never needed this, but it's a good problem. This is why the core breathing for the back, every rep the speed of the exhale matches the speed of the rep.
Okay.
So if I'm doing like push up, it's going to be but if you're going slow, so the timing of the breath matches the speed of the rep. But that's the fundamental thing to put in to it is the one movement. If I could just insert that, if I could just have to choose one thing. Do you feel deep core with that?
I absolutely do feel deep core.
Yeah.
And I work out core all the time.
Sure.
I absolutely feel deep. And I'm not just saying that, I really do. I mean, this is something, I have a motion preservation PT protocol that I give to my patients post-op, sometimes pre-op, for their PTs. Nothing is in there that talks about this.
Why? Maybe I can help you develop.
Let's do it. No, let's develop. This needs to be developed further, because what I just felt there, first of all, was awkward because it wasn't natural for me to do initially. Was actually rather incredible.
Cool.
Yeah.
Stuart McGill.
That was actually fantastic.
Great. I'm glad you liked it.
Yeah.
Flexion dominance. So you'll see in video your tendency on you felt it with the breath, but even your bend, you're losing spinal curvature unknowingly.
No, so, I knew I was.
Did you?
Yeah.
Okay.
I could tell. I had one on the full body scan that I had.
Well, you could tell you were doing it in the motion, or you could tell based on the scan.
Both.
Let's take a look at that. Let's see you do a hip hinge as far as you go down, but maintaining the natural lordosis to your back.
See, I'm fighting it.
Where is where is your natural lordosis at?
I mean, I'm actually flexing over because I'm fighting the lordosis.
So do you believe this is natural lordosis? You believe you maintain angle here?
I believe I have, yes.
It's slight. It's going to be more about. There's that'll be
which is certainly pushing it forward.
That's certainly
absolutely.
Yeah. I just teach people, they just need to know. You just have to know, okay, I'm not flexing.
But you mentioned awareness. What I felt, I was pushing myself to stay lordotic, to stay natural, and it was less than I thought I was.
More like pulling yourself.
I was pulling myself, but your point is really well taken. I was less aware of how flex I really was when I was pulling myself, trying to pull. I thought I was actually maintaining perfect lordosis.
Right. Let's take a look at the squat. Last one. Side view. This way.
Sure.
Let's take a look now. Okay. So what you're going to do here is I want you to go down to where you think is the bottom. So there's a bottom of a squat where you're maintained.
Okay.
Anything else would either kyphoticize here or flex under.
Got it.
Let's just test and go all the way to the bottom, but where you think you have maintained it.
Okay.
Pretty good. Pretty damn good right there. Let's see, that's a little actually extended, but that's an awesome bottom position of that. Like you got maybe a little extra, maybe a touch of lordosis, but you stopped at the bottom.
That's all, yeah.
You did great with that one. But that's such a test with patients. You just go, can you squat? Just have them squat. They're going to hit a point usually here where they just flip under and they have no clue.
Right. Yeah.
People say butt wink, but it's not something to dismiss.
Right.
It's a lack of control of the components of the body.
I mean, this is why our two worlds need to work together.
I feel it.
You know, there's nothing here that's antagonistic. We talked a little bit about, did I too much, too little, Natalie, blah, blah, blah. But this is good. This is good discussion because together, this type of, and I'm not just saying we're the only ones. Let this hopefully be a model. If you're a surgeon on the East Coast or you're a surgeon in South America or you're a chiro or a PT, this is the type of collaboration that I think will only benefit patients. But you have to start thinking like it. It's a paradigm shift in how we think about movement and the mechanics of the spine and the body.
I wonder how you can, because they're usually incentive, right? I'm sure you're doing public health work. Hey, surgeons, we have this great technique, whatever. You can bill 30 grand for, So
what's the incentive?
What is the incentive other than doing what's best? But personally, that's what I do. I just do what's best for the person.
I think we do what's best for people. The incentive, that's your incentive. The money, the reward, the fame, all that stuff comes if you want it. I mean, just do right by people. Look, I believe that a collaboration like this, whether it be an actual collaboration or just a theoretical, the idea of collaborating with this in mind, patients do better. And if patients do better, everything else falls into place. We want patients to do better.
I believe so too, especially in the long game.
Yeah. It's not, I put a Band-Aid on, I fix it, goodbye. I mean, I don't have that relationship with any of my patients. So I'm sure you don't either. And so it is a long game. We want to live longer and we want to live healthier
That's right.
longer. And so, we talk a lot about activities of daily living, quality of life. But for me, and I'm positive for you after this conversation, it's not enough. It's high functional quality of life. Whatever that means for you.
That's right.
High functional quality of life, high functional living. That's where happiness comes from. But in order to get there, you need to start thinking outside the box and start thinking about, maybe it's not surgery. Maybe it's a movement, alignment, a mechanics issue. Maybe it's both. How do we optimize?
Well, I have learned, I have a tendency to keep people out of healthcare because of what I see, fusions happening. But knowing that it's possible to have someone like you to go, okay, we may not want to push through this sludge for the next 2 years if we got this procedure done and then resumed afterward.
Absolutely.
The speed of recovery could potentially increase, because there is a time, and I'm definitely not against surgery. I'm just against.
You said it before.
I'm against most of them.
Yeah, me too. You said it before. You said it before. What you described as a time where you would potentially send a patient on to surgery, to me seemed absolutely medically appropriate. So that doesn't worry me. And I absolutely think that with some of these new technologies, we hope they work. And to me, that's unacceptable. That's not enough. We want to make sure that...
we hope this thing...
Yeah.
Hope we put it in there and it works.
And we need to make sure it works. And what you're discussing and what you're showing and demonstrating and showing me, that is one of the many tools that I think is underutilized. And I've never met anyone like you before, right? And I think that that's a shame, because we should have someone like you, your model, on every corner for every patient that's getting a surgery or not getting a surgery.
I'm going to share with you what's going down after this. I think you'll be very excited and interested on this one. Yeah, how to replicate this. Because right now,
it's hard to replicate ourselves,
It is, but I have a path. But the challenge I have right now is that I have thousands of active members that kind of go through, and in my audience, millions on social, blah, blah. But there's only so many people that are going to do the online work. It takes somebody.
Sure.
You can qualify them. This person is self-motivated. They are willing to do what it takes. They'll do it. There's certain people that still need this in-person stuff to do it.
Sure.
But, this is where we definitely have something right now in the cards. I'll share with you at dinner about how to duplicate this and how to make it something that could really be nationwide, and it would honestly turn the entire physical therapy industry upside down.
I like disruptive. Anything disruptive is potentially, like I say, paradigm shifts. We need to be disruptive, because if we keep doing the same old, you're part of, you're calling it the system, the medical system. It's just feeding the dragon. I mean, it's crazy. I mean, this, and it's prevalent even more so in the fusion space. And I know I'm a big anti-F word guy, but it's let's do our 6 to 8 weeks or 3 months of conservative therapy. It fails, and put rods and screws in your back, and you're someone else's problem, 5 years or 10 years later when I've retired. Because we know what happens. It can be faster than that, obviously.
Oh, if they go the pain management clinic, it'd be a lot faster.
But I mean, with the data on fusions, is at 10 years, you have over 50% chance of an adjacent segment breakdown or disease. We looked at the data between artificial facets and fusions, which is what the trials were compared to. It was like a 5.6 failure rate compared to a 25% failure rate. It's nonsensical to not be disruptive. And so I love that you're being disruptive in your space, because I'm trying to be disruptive in my space.
I would definitely say after this, I'm like, you know what? If somebody's like, I'm having surgery. Obviously, do you still do procedures? Do you still do discectomies?
Yeah, of course.
Oh, you do those?
Oh, yeah. Because not everyone needs an implant.
Right.
I mean, if you do endoscopic, microscopic, I have a good buddy down here in San Diego, Dr. Joel Kim. I mean, he's like the master of endoscopic.
Oh, Kim, I've heard about. I've never met him.
He's great. He and I collaborate, send patients back and forth all the time. Indications. What's happening? Is it you don't need, and we didn't get into it, but you don't need an artificial disc or an artificial facet or both on the majority of cases. Sometimes you just need to take down the inflammation. Sometimes you need some distraction, some traction, some decompression. Sometimes you need a little microdiscectomy because the nerve is in trouble.
Mm-hmm.
That's it.
Mm. This is where I definitely can get, I'm so deep with mechanics that I often like discount small changes in one area, like pelvic position. I go, okay, yeah, that's one thing, but now we got to get the hips high, the right hip's high because the left foot is collapsing, and that's going to cause contralateral bulge. So we have to now get the foot. So I'm so full body, but I think will be really helpful. And I've thought about it. I'm like, we need like a level 1, a level 2, and a level 3, kind of like of this body mechanics. Like level 1's simple. It's like, this is your basics. This is your mid for people who want to go more.
Sure.
I'd love to do something. I don't know what I'm like, if we could run, I don't know if we could run trials or if I'm actually willing to find a way to come up towards, I could probably stay up in LA for a period of time.
I hate to make you do that.
Oh, jeez. I avoid it up there.
No, I would love it. I mean, it would be an honor, and it would be certainly an opportunity to do something amazing. And I have a lot of patients that are traveling from out of state, to come see me. But if I could have them work with you before and after surgery, I think we could. This is my hypothesis, that we would clearly show a dramatic change in their trajectories, assuming that they're already on the surgical path.
Are those measurables important? I mean, obviously they're important to you, but is that something you measure?
Absolutely. We have all kinds of patient-reported outcomes and PROMs and SF-36. These are all like metrics that look at quality of life and how patients are doing in pain scales and ODIs. But we're always looking at our metrics, and we're always monitoring patient trajectories, how quickly we actually just published a paper with a group of quote unquote 10 experts in arthroplasty in the motion preservation space about return to activity and what the expert consensus was. And it's so funny because there's so much disagreement. And so we're looking at how quickly can someone really go back into, and these are important topics, sports, competitive sports, contact sports, regular workouts, exercises, sexual function is a big one for couples, right? Back pain, people don't talk about it, but back pain, SI, pelvic issues can affect intimacy, can affect relationships. Yeah. This is something we need to actually delve into more. I talk to my patients about it all the time. They've been very open about it. Shouldn't be taboo. This is important. It's part of human beings. Relationship it's a critical aspect, and this can be a major factor. So we're looking at all of that in terms of time frame, how quickly, how slowly, what trajectories, how fast, and that's important. Yeah. That's early recovery phase. What I would love to see is, can we change those with your type of movement, body mechanics? And this is going to be a long time coming, but can we show less adjacent segment? We talked about adjacent segment disease. So if everyone understands the idea, we talked moment arms, we talked about, fusions, and that if you're not moving, the other shock absorbers wear out faster, adjacent segment disease. So we know people who get fusions often get adjacent segment disease above and below faster because there's higher wear and tear. When you do motion preservation, we know it's less. The data is clearly less.
Makes sense.
But it's not zero, right?
Makes sense.
So, the cervical data in the neck, it was about 1/3. So it's a 66% reduction of adjacent stresses. The question is, it's not zero. And, and I want everyone to understand, if you have your own degenerative process going on at one level, you also have adjacent segment stress because that level of disease is not functioning properly. What I'm curious about is, if we do no surgery, you have a disease level and you have adjacent segment stresses because that disease shock is not functioning anymore properly. Can your work slow down adjacent segment disease?
I would love to do long-term.
It's a long-term question.
Quantitative data on that.
5 and 10 years, I would like to see if what you would do before or after a surgery in my world can actually prevent adjacent segment disease even further.
Because I'm trying to find the incentive here, and I'm like, if these device companies, if they're motivated for their part to last, then we can definitely put work into get a segment of people that focuses and understands alignment clearly, and then put it with the poor control group that's clueless.
Yeah, exactly.
And measure the outcomes.
Longevity of the device and longevity of the adjacent segments.
Is that a big one?
It's a big one.
Okay.
Because you're preventing further surgeries.
Mechanically, it makes all sense. If you have L5, S1, and let's just say you have 10% of movement left, and then you fuse it, now you have 0, and you're still flexion dominant.
4, 5, 3, 4.
You're now you're hinging now on 4, 5, and it's not because the fusion caused the adjacent. It's because you carry those shitty mechanics over with a fused segment. Now the segment above is now hinging.
Correct.
I don't think this fusion causes that.
No,
it's
but
the mechanics.
The mechanics. But the fusion does increase adjacent segment stresses because of the mechanics.
Yes.
Right? Because it's like a moment arm. And so if we can get the mechanics to be corrected and preserve motion, that adjacent segment stress goes down. But I think that it would go down even further if the mechanics were also corrected, because people have compensated and developed shitty mechanics over years of the pathology.
Sure.
And so that's what's amazing about this conversation, what's critical. And I know we're like getting into the weeds a little bit, but there is an opportunity. And then I would take it one step further. My focus right now is what are the best ways to keep you off my operating room table? And in that regard, if you have a pathological segment, and you can work on body mechanics and offload some of those stressors, then you may prevent surgery forever or longer. Maybe there's new technology, maybe something comes up. Who knows? There's a lot of patients who shouldn't get surgery. There's a lot of patients who wait too long and cause themselves harm and should have got surgery. Right. That's the nuance.
Right. Yeah, and that's the amount of, because I get about, I think my best year, we had like maybe 980 million eyeballs. And then we had probably 100 and some thousand comments. I read as many as I can, right? And so I pick up on trying, I see data that you can't even buy with research.
Yeah.
The amount of reherniated discs.
Sure.
Post discectomy.
Yeah.
To me, I'm like, well, you go in there, you needed a surgery because you're shitty mechanics, and now it cut it off. Now you got literally an open wound and I know you created a device or partnered or tested one, a plug almost.
I published a paper on that. Yeah, I was part of that. Yeah.
But then they're not getting that though. But even if they were, and of course it's going to reherniate. And now what's the typical, right? You herniate it once, you herniate twice, and then it's fusion 3, number 3. That's a classic thing.
Classic. Yeah. I mean, look, there's clear risk factors that have been looked at. Reherniation is common and the data is all over the place. But I'll quote something that someone's going to tell me is wrong because there's many people quoting things, but it's between 7 and 20% of people reherniate in the first year. That can go even higher depending on risk factors. We know about obesity, diabetes, smoking, all increase your risk of reherniation. What people don't talk about, but it's also true, is high activity. So if you have a susceptible disc that's already herniated once, depending on your healing and how fast you get back to activity, you're going to put a lot of pressure and load on a diseased disc segment and you can reherniate and your mechanics are probably bad. At the same time, if you have a discectomy, you take the herniation off and you're feeling better, I don't want to prevent you from being active. So it's about being active correctly. Right? And so it's a catch-22 a little bit. I mean, I had a patient, young 22-year-old, massive herniation, foot was getting weak, took him urgently to surgery. What did he do a few weeks after surgery? He's feeling so well. Went skydiving.
This is why I'm like this. Whenever people are in pain, they're much more motivated to put the work in pre-surgery.
Right.
Because after, you cut that disc off, nerves relieved, their brain, it just goes, it forgets, it just lives their life again.
Go skydiving. What do you think the chances are of reherniation after skydiving? Yeah. So again, I get it. You're 22. You're invincible. I get it. But if we can work on trying to get people to heal properly, yes, I did publish that paper and it was a very interesting, because we did it from a healthcare economics perspective. I was looking at the economics of this. I don't think that putting devices and plugs, and there was a long time ago, even before in my training days, there was like a special suture to try to close the annulus, the covering of the disc to prevent reherniations. There was a glue. People have tried everything. Mm-hmm. You're still getting reherniations. I think that a lot of that has to do with how you return to activity properly.
Sure. And it makes sense. Your sports, again, if you're carrying the mechanics, you have this disc cut. It's just like, hey, if you were going to walk around, let's just say you would lightly bend for a year, but now you take with those kind of shit mechanics, but then you go back in CrossFit. Sure. Now you're adding 200 pounds for 200 reps on top of that. It's just a time force.
And I'm a surgeon, and that's my problem with surgery, is that surgery to date is a trauma to the body.
Sure.
And unfortunately, we're very good at fixing problems, but we create other problems. And when we go in there, minimally invasive, endoscopic, microscopic,
laser.
We're disrupting anatomy to get to pathology to try to fix something. Sure, a lot of my mentors taught me in the brain and the spine, how to disrupt as little anatomy as possible.
Okay.
I think that's an important model.
Right.
But I think
Is that not common practice?
For many people, bigger is better, because if you can see more, if you have more exposure, you have more access, you can do more.
Yeah.
It's easier.
I see.
But in general, common practice should be, and probably is for most people, especially the latest generation of surgeons, is let's be as least disruptive as possible to the anatomic region we're going in, fix the problem, and get out. I still believe that, without a proper protocol on how to return to activity, what caused the problem in the first place, it becomes very cyclical and sometimes a snowball effect. And you're then surgery after surgery after surgery after surgery.
And these people, some people carry a lot of emotions in there. I mean, and plus there is this, what I see is people, there is a anxiety after surgery because they hope the surgeon fixed it.
Yeah.
They hope they did. They feel out of control.
But you relinquish control when you go into surgery.
That's right.
It's true.
You relinquish it,
yeah,
but you can regain control afterwards. And that's why I could use your help. The truth is, because I can show testimonials, talk about this stuff. But if I have a surgeon, a neurosurgeon that could help with this too. They could help with this, with just helping people see this path too. I think it'd be really helpful.
I'm all on board, because I think what you're doing is helping people. And again, what would we want for ourselves?
Right.
I wouldn't say no to surgery, but I would say yes when it's the right time, the appropriate surgery, the right surgeon, the right everything. So it's a careful consideration, I think. And I don't want the people listening and viewing this to think that, I'm anti-surgery. That's obviously not the case. It's the right surgery for the right patient at the right time. I've seen people modulate their pain to such an extent that it causes themselves harm, that they lose function, right? And
what do you mean, modulate pain?
So they've figured out ways to mask it, whether it be spinal cord stimulators, multiple injections, unfortunately, opiates, drugs, illicit drugs. I've seen people modulate their pain and figure out a way to control it so they can function. It becomes a vicious cycle. I've had patients come in, they're like, 2 years later, I saw them 2 years prior, they come in and their arm is flaccid, half the size, atrophied, because they have severe myelopathy, damage to the spinal cord. This is not something I can fix anymore, right? And so I'm not saying no to surgery. I'm saying appropriate surgery. And a lot of the things that we see people getting operated on can be avoided by proper mechanics. There's so much about, and you know this probably better than I do, but there's so much that we do today that creates a setup for improper mechanics, right? Like text neck, ergonomics, simple stuff, sitting, right? You know this better than I do, but
we're fighting against it.
We are constantly fighting against it.
It's always a fight
to
stay active.
And again, it gets back to what we talked about before. What changed? What was different with the person that has the same MRI, same pictures, same everything, but one became symptomatic, one didn't? How can we be better at diagnosing, preventing, getting the body working, as optimally as possible so it prevents unnecessary surgery and gets you recovered from a surgery faster?
So, this is something I want to ask you this too, realistic numbers, because I see that oftentimes the MDs, the surgeons to me, they're like the worst backseat drivers. They're like, why am I driving? Watch out.
It's not my wife is the worst backseat driver?
No. It's watch out. I had a friend that was in an accident the other day. We could be struck by lightning. I saw this accident. And so what these MDs and surgeons are doing, number one, they're trying to lay out the possible risks of not getting surgery.
Sure.
But they're ultimately laying out these 20 things that are all 1 out of 20 million.
Right.
And now people start thinking about these low likelihoods. So my question is about disc. Okay. Bulge to a herniation to a sequestered, right? But let's say someone comes a herniated disc and they go, man, I don't know. Is it let's say they have no motor issues, sensory pain. What is the risk?
Sure.
To not getting this thing done and not say they're not fixing anything.
Yeah. Again, there is very little risk in that scenario, right? Operative cases are, it depends on where. You were pointing to your legs, so we're assuming lumbar spine. A cervical disc in the neck is much more serious because there you have a solid cord, and that cord does not do well with compression, pressure. In the lumbar spine, usually below T12 or L1, some people L2, you don't have cord, you don't have a solid cord, you have cauda equina, you have nerve roots. Those nerve roots like you had mentioned before, can be moved around a little.
Yeah, they're a little more floppy and they're a little horse's tail.
A horse's tail, exactly. A little bit more floppy. And so a herniation in that space is much less urgent unless you're having motor weakness, numbness, sensory deficits, saddle groin level anesthesia, problems controlling bowel or bladder. Those are neurologic emergencies because it means the nerves are not functioning properly. Pain with a herniation, depending on the size, is not an emergency. This is something that doesn't necessarily need surgery. And so there are many, many things that can be done in your space, even in the pain management space and any space that doesn't require surgery.
The great thing about what you do is unlike what I do is you can, when you trim a disc or put an artificial, you can instantaneously reduce the pressure off of that irritated nerve root.
Correct.
What do you see with actual nerve regeneration? Because that's a challenge I run into. Someone's like, I'm getting weak. And I go, how much am I? Because I can only temporarily get them off of it until they learn it.
Right.
What do you see after that in terms of like paresthesia and motor and like returning? Is it based on time of compression? Does the nerve actually, I mean, it's trying to regenerate too, right?
Yeah, it depends on the type of nerve injury, right? You can have neuropraxia, you can have neurotomesis. It depends on if the level, if it's just the epineurium, the surface of the nerve that's injured, if it depends on if it's the actual, endoneurium and the inner layers, if you're talking about axonal degeneration, degradation. So it really depends on the level of nerve injury. So time is certainly a factor. We know that the longer a nerve is under stress, inflammation, or injury, the longer it's more permanent. We also know that nerves are very, very slow to recover, but they can recover. All of our parents told us growing up that your brain cells and your nerves don't recover, don't do drugs. They were wrong. Well, not about the doing drugs part, but they were wrong that we certainly can see neurogenesis at the axon level, at the neuron level. And so the rule of thumb is I don't like to gamble. So if someone is developing more than just pain and someone's developing symptoms of nerve injury, which would then result in nerve dysfunction, that can be motor or sensory, numbness is a problem. It's often overlooked, or true motor or control, then I don't gamble. I'm more aggressive in those situations because if I'm wrong, then it's not recoverable. For example, we said cauda equina, the horse's tail, the bottom of the spine, all those, those dangling nerve roots. I always talk about spaghetti, right? There's a syndrome called cauda equina syndrome. There's, again, literature to support, and again, all of this literature can be wrong, right? These are huge just generalizations. I could tell you how many times I've seen outliers.
I've never seen cauda equina in my career.
Yeah, so we've seen it because when you're on call at the hospital and someone comes in that their foot stopped working, they have a foot drop, they can't feel their groin area, it's called saddle anesthesia, just numbness, and they soiled themselves because they lost continence and control of bowel and bladder.
You need surgery.
That's an emergency.
Right.
The data suggests 48 hours before it becomes permanent.
Oh, on that much of
Right.
on that strong of a compression.
Yes.
The data suggests that.
The data suggests that.
Interesting.
And so most people, ethically, medically, legally, everything handles that just as quickly as possible. No one's waiting 48 hours. I've seen people with cauda equina syndrome-esque, never showed up to the emergency room, show up to the office with a year of it, we still get better.
Have you seen most the in terms of neuroplasticity, do you see that most people that lose motor function, well, what would you say statistically you see or the data you see about, let's say somebody has foot drop and they've had it for, let's say they're 50 years old.
Sure.
Maybe they've had it for 6 months, maybe they've had it for 10 years.
Yeah.
And then you would operate on them, you would cut it.
I may not operate on them in that situation, just so you know, because it's been so long standing.
I say, you might be like, the nerve is not going to come back.
Yeah, and that's an educated guess and experience, unfortunately, because we just don't. It depends on the patient. If they're very healthy, they want to be aggressive, they want to try everything. Yeah. I would ask, where were they for the last 10 years or 6 months? Right. But sometimes it's not worth the risk, depending on if they're general health, right? Yeah. If otherwise healthy and we see something that may still make sense, 6 months, maybe it's probably worth trying it. 10 years, probably not worth going after a foot drop, unfortunately.
Man, interesting. So that nerve is, so it's kind of arbitrary though. It's kind of an educated guess on.
Unfortunately, yeah. Statistically, I can give you my own personal anecdotal statistics. over a year or two of nerve injury, I've seen maybe less than 10% of people with more than 15 or 20% recovery.
Say that one more time.
Yeah. So with over a year of, let's say, something like a foot drop,
Yep.
I've seen that less than maybe 10% of people, so the vast majority, will get up to maybe a 20-25% improvement.
Wow.
That's it.
That's it, huh?
That's it. Again, which is why I'm not in any way shunning the non-surgical approach here. I'm saying, but we have to be smart about it, because there are surgical neurological emergencies that, unfortunately, there are no other ways to fix.
That has actually been one of my concerns, because of course people with some paresthesia and some little weakness.
Where's the threshold?
Where's that threshold?
Yeah, I get it.
We kind of talked about rest. We talked about choose versus need. We talked about there's nothing else you can do. Well, that was just the last one. People, what we hear surgeons saying is there's nothing else you can do. That's all.
But surgery? So, I mean, look, I actually, and I've had this conversation very frankly, open, candid conversation with my patients, saying I don't like anybody, surgeons, PTs, doctors, chiros, anyone that uses scare tactics, right? I don't like the scare tactic. An example, you mentioned it a little bit earlier. If you don't do surgery and you fall and trip when you're walking on the sidewalk, you could be paralyzed.
Totally.
Okay. But I don't need surgery right now that I'm aware of, and I could fall and trip and be paralyzed.
Right.
So do you know what I mean? And so I hate that tactic. I understand that everyone is, for the most part, is trying to do good, trying to help people, needs business, needs to pay back their student loans. I get all that. We have to do right by people. And I think the rest will come. We cannot run a clinical trial. There's no ethical or moral equipoise to say, oh, you need surgery. Let's push you down and fall and see what happens. We can't give you a statistic that says, okay, if you have a stenosis in your neck by this degree, 50%, 70%, 80%.
If you're in a mild car accident.
And you're in a mild car accident, this is what happens. And we'll test another person who has 80%. Who will do that? That's not ethical.
True.
So the truth of the matter.
Old studies back.
No, I mean, maybe. I haven't seen them. But the idea again is, okay, it makes sense. If you have this much space versus this much space, and if you fall and there's a trauma, you may have less reserve than someone who has no stenosis, no tightening on the nerves. Maybe that's true.
Less reserve,
but we don't know the number. We don't know how much less reserve. And so is that the fear of there being a problem, the impetus to do surgery? I think that that's inappropriate. I think that you should be honest. And you say, you may have less reserve. Yes, you may be at more risk.
Maybe.
At more risk if you had a fall. But I could literally, God forbid, walk across the street, get hit by a car, and also be paralyzed.
That's a good way of looking at it.
I mean, we just don't know. And so I don't like this. I don't believe in prophylactic surgery. I don't believe we operate to prevent something. We operate when we have a problem that is fixable safely, if possible safely, and we've tried everything else, and that's what we've been discussing about today. What does that mean? Everything else and the time frame. And in my opinion, and in your opinion, it seems, the everything else has been wholly inadequate.
Fair. From my opinion, from what I see, yeah.
Right.
Wholly inadequate. That's a good one, actually.
What would you want done to yourself?
Right. That's great.
Right? You want me to give you an artificial disc? I'll do it once you've tried everything. Whatever that means.
Whatever that means.
But I mean,
hopefully we got a little closer to that today.
We got a little closer, but I think maybe we'll talk more. Maybe we'll do some social media stuff, but more importantly, in the background, we're going to work together and figure out what that means.
I'd love that.
I mean, I think that's the goal of this.
If I knew that we can create a strict set of what that means to get there, that could literally be, that would be worth my time.
Mine too.
In this too.
But that's the most disruptive thing that we can do.
Interesting.
Let's disrupt the pathway. Let's get people on a better path, because we're saying that we can do it differently, and the trajectories with surgery or without surgery could be better.
Love it. So if we can wrap it up today, what we did is I really went into this one because I was so happy to have you, because you're a motion preserving neurosurgeon.
I'm glad to be here.
All the credibility plus motion preserving, which is, you're amongst that small percentage of the cutting edge, and you've done your work. I mean, you've taken part of multiple research, not only for surgery but for public health and cost savings amongst surgeons too. And by the way, I looked at all your reviews too. Your patients love you. You have a fine reputation.
Thank you.
Yeah. And so super, appreciate you taking the time to fly 20 minutes down here.
It's a whole other argument for another day.
and be here for this. And really wanted to set today to really work on crafting a set of criteria that would qualify people for surgery, that would guide them to better results if they do choose to have surgery, to separate what is a choice and what is a need of surgery,
Sure.
to address some common things that we hear out there about conservative care. I think we covered that. To get into some details about the different motion preserving surgeries, procedures that you offer, which are really awesome. I think I could, I'd love to, like with this medical, we'll talk about that at dinner, but I get a lot of ideas afterwards too. So I really appreciate you taking the time to be here, and hopefully we can it up.
Yeah, I appreciate being here.
Yeah, and hopefully we, do you have anything final to add or?
No, I commend what you're doing. I really do.
Thank you. I really appreciate hearing that from you.
Yeah, absolutely. And I appreciate you having me and taking the time as well. I mean, this has been great.
Cool.
So it was worth the 20-minute flight. That's a flare. It's a fair plug. I like a fair plug.
And everyone out there, you know the drill. Go fix your shit already.
Yeah.
Fix yo shit.
Couldn't agree more.
All right.
Love it.
Thank you. That was